Great. Thank you. Okay, so I'm going to call to order the OEB Strategies on Evidence and Outcomes Work Group, SEOW, October 4th, 2022. We're meeting virtually, and we'll go ahead and get started. Today is an interesting day in that we're going to be doing something completely different. Well, not completely different. What we're doing is expanding our scope by inviting board members from PEB, and with the idea of looking at elements of the healthcare that both OEB and PEB present, but that are very, very similar. And the idea was to look for when OEB and PEB can do things collaboratively. So it was with that in mind that we wanted to do a pilot. And the first one that we thought would be very helpful would be to have us look jointly at the quality outcomes from our health plans and see whether or not how we can learn from each other the experience of OEB and PEB. So with that, we have two members. We're very fortunate to have two members of PEB, Andrea Foltz and Greg Closer. And I don't know if I pronounced your names correctly for either of you two. What I thought we would do is have each of the SEOW members and Andrea and Greg introduce ourselves and give a two-sentence background so that we got to know each other a little bit. I'm going to start. I'm Tom Silterbo. I'm a retired family medicine physician who had a 30-year career with Kaiser Permanente. This is my 7th year on the board of OEB, and I fill one of the health policy experts role that the OEB board has. So Robert, could you introduce yourself?
Sure. I'm Robert Young. I am currently the board chair for OEB. My day job, I work for the Oregon Education Association, and before that, I was a 14-year high school teacher.
Bill.
Hi, Bill Gropp. I am on the North Marion School Board and also on the board of directors for the Oregon School Boards Association statewide, and representing school boards. My day job is that I've been 42 years in semiconductors, from manufacturing to design and various other components, and work at Siemens.
Super, thanks. Andrea, are you on board?
I am. I'm Andrea Foltz. I am an associate professor at Oregon Institute of Technology. I teach communication, also worked for several years as an advisor to our paramedic program, which is joint with OHSU. And I'm here representing AAUP and, of course, all Oregonians. And I'm excited to see what you guys got.
Thank you so much. And Greg.
Good morning. My name is Greg, and it's Clouser. You were close. My name is Greg Clouser. I am a 23-year corrections corporal working in Oregon at the state facility, state prison. I sat on the PMAC board, which is the PEB member advisory board, for about 7 years, and this last year moved over to the PEB board itself. And as Andrea said, we're excited to help out and see what we can do and get together on. Yeah. So thank you very much.
Thank you so much. What I'm going to be, just in terms of how the SEOW group works, we don't vote on anything. We don't have any decision-making capacity. We recommend things to our board, and the way that we make decisions is by consensus. So a lot of it is information and vetting new ideas, and we get into the weeds as compared to what the whole board is able to do. When we have a topic, we'll oftentimes have our presenters tell us what what they think is going on, and then we will discuss it, ask questions. Sometimes we'll come up with a recommendations, pretty much thumbs up, thumbs down type of approach. I will kind of circle back and make sure we get everybody's opinion. So, for when you're here with Greg and Andrea, when you're with us, you have the same voice as everyone else, every other committee member has as we move forward. The one person who is late, I mentioned, was Jeff Brown. Jeff has been on the board for 8 years and was our board chair before Robert. His background is in the medical consulting business. He was the lead for OEB with Willis Towers Watson. I think it started out as Wyatt Watson, and it went through 3 or 4 different iterations. And this last year, of course, we've consolidated to where we have one consultant for both OEB and PEB, and that's Mercer now. But Jeff fills the second of the 2 health policy positions that our board has. Okay, with that as an introduction, again, anytime you all have questions, you can interrupt. You can also use the function, the raise the hand function. I watch that all the time. And with that, we'll move forward. The first thing that we have is the SEOW meeting synopsis that was in your packet. Any questions or comments about it? If not, we'll have. I think we voted in the past. We don't actually. Again, we don't vote, so we'll just acknowledge that it is without any objection. Okay. So now we're moving on to a presentation by our consultants, and Kirsten, I think you're going to be taking the lead on this. When we started to think about OEB and PEB working together at SEOW, we realized that it would be very helpful for both the PEB members to understand how OEB is organized and the OEB members to see how PEB is organized, and what the current situation around health plans and various types of benefit coverages that we offer. So it was with that in mind that we asked, again, Mercer to put together a 101, a very short educational process. Andrea, maybe we can get 1 credit for it, right? I'm just kidding. Okay. All right. So onward. Kirsten, you're on.
Great. Thanks, Tom. Hi, Andrea and Greg. Thank you so much for joining today. It's great to meet you. We're very happy to have you here. Since I'll be new to you, maybe I'll just say one thing about me. So I'm Kirsten Staveland, and I'm the lead actuary on the Mercer OEB engagement. And then I also wanted to mention my colleague, Andrew Hoffheimer. He'll be more familiar to you. He's also on the meeting this morning. So as we go forward with this presentation, if more detailed questions come up about PEB, he'll jump in and help me handle those. So as Tom mentioned, the idea with this presentation was both for members who are most familiar with OEB and then members who are most familiar with PEB to do a little comparison between OEB and PEB. And I won't give away all the conclusions, but maybe as we go through this presentation, I'll invite you to kind of think in your own mind, like, wow, I didn't know that. I thought this was really different. Actually, that's something that's really similar. Or I thought this was really similar, but actually it's turning out to be different. And then, we have until 9:50 for this presentation. So we have lots of time for questions and discussions, and we can collectively decide on some of our conclusions and takeaways, and if we want to do a deeper dive on anything at the end. So we're going to start with a little discussion about the operations of PEB versus OEB and identity. So what are the missions and values of OEB and PEB? We'll talk about some health plan benefit design differences and similarities, and then we'll kind of wrap everything up together. Hopefully have a robust discussion along the way and come away with some really interesting takeaways. So Rose, next slide. Next slide. Thank you so much. All right, so let's talk about the membership for OEB and PEB. OEB, 255 school districts, community colleges, educational service districts, and local governments. PEB also has an educational aspect with the university system. Aside from that, PEB has 113 state agencies, plus state lottery employees, some semi-independent agency employees, and local governments. Joining OEB and PEB is a pretty similar process for entities who are not already a part of OEB and PEB. They submit an interest form, go through an underwriting process that looks at their current plan portfolio and rates and compares that to current OEB plan portfolio and rates. And depending on how those rates compare, they can come in at current rates or maybe slightly higher rates. The group will make a decision. It's always a balance between member disruption, savings, other factors, and then it kicks over into the implementation phase. In terms of attracting entities into OEB and PEB, again, kind of the same questions come up, which is we have to find these entities that aren't currently part of our group, outreach to them. In order to get them to want to come on board, we have to have plans that are competitively priced, but also competitive in terms of design compared to what they currently have. And that's both with plan choice and also carrier choice. Rose, thank you. So now we have a couple data slides. So, Mercer has PEB data and OEB data available. So it's been a really fun and interesting exercise for us to be able to do the analysis for OEB and PEB side by side now. So we're going to look at a couple different slices of the population. This one is a high-level cut of enrollment by healthcare region. So we're using down in the lower right-hand side of the slide, you'll see our color-coded map of the state of Oregon. So we've divided up the Oregon into different regions, with the gray being out of state. And we have both the employee count, so subscribers, and also members. So I don't know if many of you thought how OEB and PEB compared to each other in terms of size. We can see OEB is about 56,000 subscribers and PEB is about 54,000 subscribers. In terms of membership, also very similar. Total members for OEB, 135,000, and for PEB, 136,000. So the size of OEB and PEB is not a difference. But I don't know if any of you guys noticed, there's a geographical difference. There are a couple of minor geographical differences, but there's one major geographical difference that I thought was really interesting. And it has to do with how much enrollment is concentrated in the Willamette Valley area versus the metro region. So that's that navy blue. And it's probably not surprising, right, because of where Salem is located, but it's that navy blue versus hot pink trade-off that we see. Rose, next slide. Average age by healthcare region. So overall, the average age for OEB for employees is 46.5 years. And interestingly enough, for PEB, it's actually 46.3. So the average age for the enrolled subscribers is almost identical. If you're interested, we have a couple different age breakouts below. The employee age is in that darkest, boldest line, again, showing by region. And then the spouse age is next to it, and the child age down below. So please, ask questions. And Andrew's helping me. We can watch for hands that get raised as well. All right, Rose, next slide, please. Okay, this is a risk score by healthcare region. So I want to set this slide up because you might immediately go, oh my gosh, those are really different. So let me tell you what these are, first of all. So we combined all of the OEB and all of the PEB members together and got an average risk score and made that the average, our 1.0 that we're anchoring to. And then compared PEB by region relative to the overall OEB and PEB average, and then compared OEB to the overall total. So these are relative risk scores because they're relative to each other. OWEB is lower with the 0.91. It's about 10% below average. And then PEB is about 10% above average. And you can see the risk score variation by region. It's not one particular region that's driving that difference in risk score. It's a pretty consistent difference across all of the regions. I know I thought that was a really interesting takeaway. I put it as maybe a Mercer suggestion for something that we would explore later. Robert, you had a question?
Yes.
Yeah, thanks, Kirsten. So just my ignorance on risk scores, that this mostly impacts premium rates, or does it factor into other things?
Yeah, thanks, Robert. Risk score is a really great tool, and that would impact indirectly, it would impact premiums, but maybe I would say there's a middle step. So risk score can help inform, hey, maybe this population has healthcare needs that are going unmet, or maybe they have more healthcare needs than a different population, and would allow us to dive into that group and understand what chronic conditions do you have? What are the drivers of your risk score? We might put in additional programs in place, provide those members some extra care. Those things could impact premium down the line.
And this is Tom. This is an area, as Kirsten just said, we will, this was one of the kind of the ahas and ones that we will explore and understand why there is this, what makes up this discrepancy. Is it disease incidence? Is it, we're not sure. And this is one that we'll explore and get to the point where we understand, because it is a risk scores usually relate to disease burden, and we need to understand that, and because disease burden then go on and drive costs, and so we'll learn more about this. But this was one of those aha moments that we will get and understand to a greater degree.
Kirsten, I have one other just general question. Is there any link between risk score and utilization? Or are they totally separate?
Score is, as Tom mentioned, it's driven by the underlying diagnosis. You might argue that, again, there's sort of an indirect relationship there, which is maybe there's an underutilization of certain chronic condition management services that would lead to a higher risk score. And then once there was an intervention put in place, you would want to see an increase in utilization for those disease management services that you put in place.
Okay, great.
Great,
Thank
Rose.
you, Kirsten.
Yeah, of course, you guys. Thanks. Great questions. Okay, so here's a slide about premium funding, where the money comes from. They have in common money coming from the state general fund. OWEB also has a major component of premium from local property taxes, and it's allocated on a per student per year allotment. PEB has, in addition to the state general fund, some federal funds, some lottery funds, and other fee-based funds that are helping to pay for the employer side of the premium. Rose, next slide. Premium rates. Again, I want to set this slide up. So this is a slide that shows premium for medical, dental, and vision combined. So it's kind of a unique metric on a per member per month basis from 2014 to 2021, and OWEB in navy blue next to PEB in green. And then we also have calculated for that time period the average increase. I love that they came out both roughly 3.4%. Obviously, there's a reason for that. We've been managing to 3.4% during this time period. I just wanted to mention that you'll notice the PEB premiums are slightly higher than the OWEB premiums, and that's a takeaway as well. It doesn't necessarily mean anything at this point. We've already noticed there's one difference between OWEB and PEB, which is the risk score and perhaps the disease burden of the groups. And that could translate into premium. But there are many other differences between the entities that especially you'll see later. One of those is plan design. And there's a large plan design difference between PEB and OEB. So lots of factors that could be driving the difference in premium. So we don't want to make any conclusions at this point about why they're different. Maybe just notice that they are a little bit different. Bill, did you have a question? Or
Yes.
Yeah.
On this slide, this is, I want a level deeper. Can someone maybe on the PEB site explain to me how it's done on OEB side? Each school district or entity, as we'll call it in this presentation, negotiates the actual cost to the member individually by entities, and on the PEB side, it's agencies. Do each agency negotiate a contract with their employees, or is there one contract for all PEB that tells what the actual cost is to the member? As in how much the entity is paying and how much the member is paying.
you're talking about the employer portion of the premium funding bill?
Yeah, well, yeah, the split between the employer, and how much is contributed to HSAs. Is it individually negotiated by agencies, or is there one set rate done by the state for PEB?
Yeah, we actually have, Rose, it might be the next slide. We actually have a slide, Bill, that will help guide.
So that's funding. That's funding. I'm talking about actual cost to the member.
This is Ollie. Bill, it's actually statewide. It's not by agency. Talking about the portion of PEB that's state agencies under the executive branch. So the executive branch, for the most part, or I should say for the majority of the statewide number of employees, they negotiate the cost share. But there are some smaller negotiations, other unions that negotiate their own contracts, but it's far different from OEB in that respect, where probably 90% of it is under one contract.
So ODOT, OHA, and DAS and others all receive approximately the same charge to their employees, not like what we do in OEB, right? Okay.
Right. Not in the 90 percentile. I think ODOT has some kind of smaller bargaining units within it and some other, but yeah, for the most part, it's and I think we do get into the split a little bit later, and then universities have their own arrangement as well, and it's kind of again like a 90%, and then some smaller bargaining units within that.
Okay, thanks.
Corrections as well, Bill. We do our contracts. We do a 5 or 1, just depending. But we basically do a percentage of what we pay as the member.
Yeah, but it's the same. It's approximately the same for all agencies.
Yeah, one big difference is I think the executive department negotiates a contract, and then a lot of the smaller bargaining units they generally have always fallen in line and had very, very similar, if not exactly the same kind of arrangement when it comes to the premium cost share.
But just for the PEB people, just stating that if you picked 5 school districts at random, you would see wildly different methods of how members are charged.
Yeah, that's a huge difference there.
Tom, you had your hand up also.
Yeah. So the question can we go back a slide? I wanted to this is premium. In other words, this is what is charged to the individual versus, we know that for PEB, they have very high employer contribution levels. And we know that for OEB, it's not as high. Does that explain this differential?
Thanks for asking that question, Tom. This is actually total premium. So think of this as total healthcare costs the claims
Got it.
cost plus the expense portion together.
Got it.
That we've not taken any taken contributions into account at this point. It's just total
Okay.
program
So,
costs.
so this, yeah, so that's it's important to acknowledge that one, there's a differentiation in terms of the cost of care,
Yeah.
as reflected here. And then there's an additional question around, okay, of that $556 per member per month that PEB is paying in 2021, that some of it is being paid by the entity and some of the premium is being paid by the member.
That's correct.
Got it. Okay. And so this, as you said, this is something, there's a lot of things that make up this, and we don't have the information to be able to say good, bad, right, wrong. The fact that there is that differentiation in risk scores between OEB and PEB, this reflects it.
Yeah, undoubtedly the risk score difference is reflected in the premium difference. Also, plan design difference is a significant aspect, and there are others as well.
Okay, great, thank you. And we will get into that. We'll figure it out over time.
Yeah,
Thank
it's
you.
very interesting.
Yeah, thank you.
Yeah. So we talked a lot about this slide actually already, but maybe I'll just point out, because this is another really interesting thing about OEB. I think OEB's contribution structure is generally more complicated than PEB's. Also, as Bill mentioned, there's a ton of amount of variation between the different entities and what that dollar contribution is. It covers all benefits, and also entities can choose between tiered or composite rate structures, whereas PEB is tiered only. And because there are so many varying levels of dollar contribution amount, there's a less visibility into how that translates to, if we wanted to do an apples to apples comparison between OEB and PEB, it would be a harder exercise to understand just what percentage of premium is being contributed overall by the entities in OEB. Rose, next slide. The next one. Great, we wanted to have a slide that talked about the leadership structure, and we specifically wanted to call out that this is post Senate Bill 1067, because I understand from talking to staff in the development of this presentation that prior to Senate Bill 1067, OEB and PEB staff shared a building, but that was roughly as much overlap as there were between the two groups. And now we have common management, of course. Ali is the captain of the ship, and then there's operational, the operational staff lead both as well. So Damian Braco and Cindy Bowman as well lead the team. And then the OEB and PEB boards have remained separate. As Tom mentioned, we have some PEB guests today for SEOW, so there's a little bit of integration on SEOW, and then there's also something called IWG. Rose, if you'll go ahead one slide. So we can see here maybe a statewide picture of.
Kirsten, Ali had his hand up.
Oh, I'm sorry, Ali. Go ahead.
Oh, no worries at all. Yeah, I just wanted to comment on Senate Bill 1067, make sure everybody's kind of is familiar with that bill. That was from 2017 and was called the Cost Containment Bill. And actually a big reason why we're all here today is from Senate Bill 1067. It directed the administrations of PEB and OEB to merge. It directed a joint consultant contract, selecting one consultant firm. And it really kind of encouraged staff and the boards to look for opportunities to jointly use leverage purchasing power and data and other influences. And I think this is, an opportunity with SEOW, again, why we're here today, is to look for other opportunities to look at things jointly where it makes sense. Not all, it doesn't make sense all the time, but this is definitely one of the reasons why we're here today. Thank you.
Yeah, thanks, Ali. I won't read through all of the different stakeholders and influences listed on this slide, but I will just point out to you that PEB and OEB both sit in a very complex structure of stakeholders and influencers that goes all the way up to the governor and the state legislature. And then PEB and OEB and the decisions that the board makes are influenced by various committees, the PEB Member Advisory Committee, Innovation Work Group, this group, the SEOW Committee. OEB has a Member Advisory Committee as well. Different committees such as the Health Equity Committee, the Metrics Committee also inform the work that we do. And then all the different recipients of the work that PEB and OEB do as well. So it's a statewide reach, both in terms of who's influencing OEB and PEB, and then also the influence that OEB and PEB have on the state. Next slide. A note on board structure. Again, this is a little bit of a difference, right? In terms of sectors that are represented. So for PEB, 4 board seats representing management, 4 representing labor, and then 2 non-voting advisory members. On PEB, we have some school board membership, education management, education non-management, 2 health policy experts. Tom mentioned again, he was one of those roles, and then 2 board seats representing local government, management, and non-management. Next slide. Okay, so we have a couple slides on identity in terms of where our OEB and PEB have a shared vision, and then what are some differences. So OEB and PEB, I feel like this was a big key takeaway for me as well. OEB and PEB have a lot of alignment in terms of mission and vision for their healthcare programs. And we summarize them in the following bullet points. To balance guidance and needs of a complex network of influencers and stakeholders, to leverage purchasing power to improve health outcomes and lower costs, to close gaps in care, including those caused by health inequities through standards, reporting, and accountability, provide employees and their families a meaningful choice of affordable, high-quality plans, drive healthcare and health insurance innovation and transformation across the state of Oregon. Coordinated care and value-based purchasing are 2 examples, and provide equitable, world-class customer service to all members wherever they are in the state. I also, when I put together this slide, felt like members are lucky to be getting care from OEB and PEB because these are really powerful statements. Rose, next slide. Here's some unique characteristics, and they're primarily operational. We talked about employer contribution. Bill, did you have a question?
Just a quick one on the last slide. Does PEB have region-wide representation? It just says 4 and 4. Do they strive to get people from around the state, or is it just whoever?
Greg, I believe you're from Eastern Oregon, right?
Yes, I am. And PEB is statewide. We have individuals all over.
Yeah, as much as we can. We have board members that with only 8, we don't cover the entire state, but yeah, we definitely do, Bill, look for opportunities to have each region represented.
Thanks.
Great, so some unique characteristics just to finish off our list. Employer contribution, how that's set and how much it is. Employee choice of carrier and plans. You'll see that in some upcoming slides. Plan year, interestingly, PEB is a 1-1 calendar year plan year. OEB is a 10-1 plan year. Plan funding, this has to do with self-insured versus not self-insured. The geographic distribution, as we saw, the concentration between Willamette Valley and Metro. The sectors represented, that was some industries that we touched on, and then separate boards, even though there is common leadership. Bill?
Is there any look at unique characteristics between the demographics, between the membership, between the 2, male, female, Hispanic, blah, 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 all the deeper dives that we go into equity? Is there any look at to see the uniqueness of that between the 2?
Yeah, not in this deck, Bill. We did look at, I think we wound up not including a slide with gender, even though we pulled that data. There's a slight gender difference. OEB is a tiny bit more female than PEB is when we're looking at subscribers, not dramatically so. And then for this deck, we did not pull race information. We don't have that available in our data warehouse, but I know we're encouraging the carriers to be bringing in that information as they're presenting on OEB and PEB.
And Bill, this is Tom. The one of the quality metrics that PEB is looking at that OEB has not taken on yet has to do with meaningful language access. My guess is that one of the things that's driven that is a potentially larger percentage of people where English is not their primary language. That is something that we're going to, that OEB needs to look at, and it will be maybe one of the first quality metrics that we look at from a standpoint of health equity is meaningful language. It's the conversation, if you remember, from last month around looking at the dental plans where Delta Dental didn't require the ability to have translation available as an issue. So I think we'll pursue that over this year. We'll get at the issue that you're raising.
Thanks.
Yeah, I think it would fall naturally when we do that risk score deep dive. I think that would be a natural time to be looking at the data that way.
Kirsten, the one thing that always sticks out to me as far as demographic differences is that, and it's been a while since I've looked at it, but I believe OEB has considerably more retirees in the large group than PEB does, which really is kind of, when you look at average age, I think the average active employee age for OEB is considerably lower than PEB. That's something we could probably pull out.
Yes, I'm so glad you mentioned that, Ali, because I was, as I was thinking through this presentation ahead of time earlier this morning on my stationary bike, and I was thinking about differences in premium, I was thinking about the retiree population because that would also be a potential difference, maybe even in the other direction between healthcare costs, because we know retirees cost significantly more than active employees. I think that would be a great item also to include in our risk score deep dive / premium investigation.
Yeah, and for PEB, usually the plans are so expensive, and obviously the actuarial value is very high that if you're early retiree and you choose to purchase a PEB plan, that usually means you're going to be a significant utilizer. So you get people with some existing issues. So
yeah, interesting. Oh, hi, Jeff. Good morning. You have a question?
Good morning. Hopefully you haven't covered this already, but does that retiree element add significantly to the risk score?
Yes, a question that we're raising, Jeff, as part of one of our takeaways for this presentation will be to do a deeper dive on risk score and include some additional metrics and data. And one of those will be retiree healthcare costs. And this idea that Ali's mentioning is that due to, we'll call it the high barrier to entry of the higher premium costs for the early retirees for PEB, we would expect there to be some selection. So sicker PEB members would be electing into that early retiree benefit with PEB, and that would impact both risk score and also costs. So that'll be an important element to look at.
To me, it would be good to see the two, retiree and active.
Yeah, 100%.
So we can look at that. Thank you.
Yeah. Rose, next slide. So now we have a couple slides that compare plan offerings for OEB and PEB. So we'll look at the different carriers that are offered. We'll look at the different plans that are offered, both in terms of level of care coordination and then also in terms of plan design. OEB offers members the choice of two carriers, Kaiser and Moda. The enrollment split is 25% Kaiser, 75% Moda at this point. PEB, you'll notice, has an orange slice that OEB does not. That is Providence. And within the PEB membership, 66%, 2/3 are enrolled in Providence plans, 19% in Kaiser, and 15% in Moda. Next slide, Rose, please. Thank you. Okay, so here's a slide. We just wanted to show plan design separate from the care coordination element. So OEB actually has Yes, OEB has 10 different plan designs. Kaiser has 3 deductible levels, the 0, the 800, and the 1600. And then through MODA, we have a $400 deductible option all the way up to a $2,000 deductible option. And I was really wishing this morning I'd calculated an enrollment weighted average deductible for OEB and PEB, because it would be just a really high level metric to compare the difference in plan design. But we can visually see it. If we look over at PEB, Kaiser has 2 plan designs offered, $175 deductible and a $1,400 deductible plan. But then the plans offered through MODA and Providence actually has 2 plans, but they have the same deductible. So we've consolidated that into one plan here, are both $250. So you can, without doing the math, it's obvious that PEB has a much lower average deductible available to its members. Next slide. Sapari, do you have a question?
Kirsten, yes, I do. Thank you. I just wanted to clarify for the prior slide for the PEB plans that Kaiser has a traditional 0 cost deductible plan and a 250/750 deductible plan. So just a minor correction there.
Oh yeah, thanks. I'm sorry about that.
Oh, no worries. No worries. Thank you.
And the question that I had was, how do you, of the 35,000 PEB members who are part of the Providence Health Plan, how do they divide out in terms of numbers of subscribers for choice versus the PPO?
Yeah, so if we skip this slide, and that was just enrollment by tier anyway, so we'll skip ahead a slide, and this will answer your question, Tom.
Okay,
so
thank you.
Yeah, we have, we'll answer your question first, and then we'll talk about the rest of the slide. So the very bottom row says what percentage of the enrollment in that plan is in the coordinated care versus non-coordinated care plan. So for Providence Choice, it would be 52% of the enrollment in the choice plan versus 48% not in the choice plan. But I will just point out to this audience that there's probably, and this came up in carrier discussions leading up to this meeting, a little like some ghost impact from physicians complying with the coordinated care plan design requirements and operating in that method. People in the non-coordinated care plans might be getting a little bit of that benefit as well. But this shows enrollment by plan, percentage of enrollment by plan for Kaiser MODA, and then Providence Kaiser MODA for PEP.
Great.
All right, we're running right on time. Next slide, please, Rose. Okay, and hi, Bill.
Sorry to interrupt again. On the previous
great.
slide, I was just wondering, we in OEB, had MODA really push hard a program for pushing people into the coordinated care. Did PEB do a similar thing with Providence, their dominant healthcare carrier?
Yeah, I can answer that. Definitely. It's pretty interesting to look at year over year. I'd say like over the last 6 years, you see a pretty consistent proportion every year of migration into those coordinated care model plans across PEB and OEB. I think it's every year you see that number going up, and until I think maybe it was 3 years ago where there was more enrollment in the coordinated care model plans than in the PPOs.
Thanks.
Great, so these are just some ideas that we had by the time that we had put this presentation, finished putting this presentation together. So some key takeaways that OEB and PEB are basically 100% aligned in mission. There are some operational differences in execution, some geographical differences, Metro versus Willamette Valley, but no meaningful difference in age, and then a difference in risk score, and also we saw a difference in premium. I'd be interested to hear from the group other things that you noticed or wanted to add to the takeaways list. We have the retiree and race ethnicity question as part of our demographic risk score deep dive.
Yeah, and part of that race ethnicity is going to be, okay, what can what's meaningful about it from a standpoint of services and healthcare access, it would be looking at language. Would, I think, is a starting point. I know that's where the CCOs are starting in terms of their push towards health equity. Ali, I think, is that correct? Did I get that right?
Yeah, you did. And, you know, I think with our new system development, you know, we have the ability, and I probably should let Damien talk about this instead of me, but we have the ability to capture the real deed data, but we want the carriers, and obviously they're required to do it, to be that data store, because we get the data in our data warehouse from the carriers. Did I get that correct, Damien?
You did.
Okay, thank you.
Great. I think this is very a wonderful summary slide. I'm going to be bringing this to the full board this afternoon, and also we'll be talking about the aligned characteristics and the unique characteristics. So very helpful.
Robert, did you have a question or comment?
Yes, it's a comment. So let me get rid of my hand. I think not necessarily on the key takeaways, but if we could have some type of 201 presentation, I have some ideas or requests on that. What would be, what are the funding differences? Because I know that PEB and OEB are funded differently, but it's really hard for me to explain to the average member how that makes a difference. Also, I know we compared premiums, but it'd be nice to compare the benefit differences of each of the plans if we're going to do a deep dive. And also the dollar cost to members comparisons, if we could look at that. I know that's difficult maybe on the OEB side, but I actually do have the data on that. So maybe we can work together on that. And then also, you had a slide at the very beginning that local governments could join PEB and OEB. It'd be nice to know how a local government would choose between the two and what the entry requirements are for both OEB and PEB.
Those are great ideas. I love the idea of a 201 presentation.
I think it'd be 102 if it's this year. It'd be in the same semester. Next year it'd be 201.
See,
I'm just trying to respond to having Andrea along board. I wanted to make sure I got it right.
Yeah, those are great. Those are great thoughts. And we could even do a 103 as well. I mean, wherever it takes us, definitely.
Super. Kirsten, are we done?
Yep, we're wrapped up. It's time for the next one.
You landed that at within a minute of that's pretty darn awesome. Great comments and questions from everybody on board. Bill.
I just want to request, and I'm not saying I can do this, it depends on the time, but if each board can get a schedule of the other board's meetings, maybe we can join and just listen in a fly on the wall to what the other side looks like in their board meeting.
Absolutely.
I'm sure Rose sends out an announcement to I don't know, probably a cast of hundreds about the presence of the OEB meetings, and probably does the same for PEB. My guess is just that OEB board members are not part of that distro and vice versa, and it's something that could easily be done, I'm sure.
Yeah.
Okay. I want to thank Kirsten for this. This was something that we've been talking about over the summer and putting together, and wonderfully done presentation. And as I say, we'll do more over time. We're now going to transition into our annual review of quality metrics and our clinical performance metrics. And I want to welcome we have the Kaiser Permanente and the MODA staff that SEOW is very familiar with, I wanted to now welcome the Providence Health Plan people. Obviously have been a major part of PEB's quality program for years and years and years. And as we do this joint effort, I would like to welcome Providence to our meeting. And Robert, I saw Robert Gluckman's name come up. Robert, are you there?
I'm here, Tom.
Great.
Nice to see you again after
wonderful.
a lot of years. I go by Bob.
It's been a while. It's been a little bit. And also, you're going to be joined by, was it Rebecca Allen Hines?
Haima.
Rebecca great.
Allen
I'm
Haima.
sorry. Great. My eyes aren't all that good these days. So thank you very much.
Problem.
We'll get your presentation as a little bit later, but welcome. And with that, I think we'll jump into the meetings. And the first group up is Kaiser Permanente, and Dr. Keith Bachman is going to lead our presentation. Keith,
Great.
you're on.
Great, thank you. Good morning, Tom. Good morning, OWEB board and PEB board guests and staff. Happy to be here to talk about our quality performance. The presentation is kind of set up in a series going through all the metrics, performance metrics listed really in the order that's in our contract. So it's not a terribly rational order. And it's a sort of set of 3 slides we're repeating 4 times. The first slide being kind of background data for OWEB in the peach color and PEB in the light blue. And then the HEDIS 75th percentile CCO benchmark in white, both 2019 and 2020. The next slide will have 2021 data. It's a 2021 measurement year data. And then the third slide will be narrative and talking about our performance improvement measures. I do have 2 guests today who are both content and subject experts and really instrumental in all aspects of quality performance, chronic condition management, and prevention management services. Kaiser Permanente, those are Yvonne Rice, who's our Director of Clinical Quality Systems, and Dr. Catherine Glassberg, who's our Medical Director for Quality and Health Equity. That's a new position in an organization, adding the health equity, recognizing that health equity and quality are really 2 sides of exactly the same coin. And as we move forward, we know our work, and our current work and our future work is really simultaneously improving quality and improving health equity, recognizing we can't do one without the other. I don't need to say this, but it's obviously been a complicated, distressing, difficult, challenging world for our members, our communities, all of our healthcare systems that see OWEB and PEB members, and really all healthcare systems around the state and country. And you'll see that reflected in the data. We kind of have 2019 as baseline data showing on average for Kaiser Permanente, our traditional excellent performances on the HEDIS metrics. You see challenges, huge challenges in 2020, and then improvement in 2021. And those are a little bit different as we go through each measure. I would say you could say this COVID and the quick transitions in care, shutting down initially, then seeing flexes in care related to staffing, related to further surges being sort of a natural experiment. Unfortunately, we didn't have a control group. I think in a perfect world, you could pilot quality improvement efforts and see how, we see how that works and then amplify it if it works well and back off of it if it doesn't. Well, we really couldn't do that this time, and you're seeing sort of various effects as we move to a virtual environment or emphasized a virtual environment, as we were challenged to bring in our usual quality improvement or quality management efforts that we do face-to-face during office visits and struggle to do those during a virtual care environment. And I think more recently in 2021, we're developing, as everybody else has, with staffing challenges, where we were really, rather than deploying staff in the virtual environment for the LPNs and the medical assistants, really we're keeping those people in clinic because that's a much more complicated environment and needs that. So we've seen some deterioration in these numbers, and there's each of these metrics has a complicated book of strategies, tactics, roles for each member of the healthcare team to do. With that, I think we can go on. So you can see the baseline there. We did in 2019, really everything was sort of green. Everything was going as expected, 75th percentile, many in the 90th percentile. You can see in 2020, really deteriorations on things, particularly that rely on office visits, such as childhood adolescent well screenings, some immunizations. We actually turned off colorectal cancer screening for a while, which I think we're still seeing the effects of that. We didn't have capacity for colonoscopies, and we felt it wasn't appropriate to continue to do our stool fit testing program during that, and then blood pressure management, which also the HEDIS metrics require office visits for that. Anyway, next slide, please. So you can toggle back and forth and see, and some of these measures have come back up very well, like colorectal cancer screening, though it hasn't yet come back to the levels that we've seen in the past. Childhood immunization is doing very well. Childhood adolescent well care visits, the top line there, are improving about halfway back to from the nadir to our expected performance. And antidepressant management is also not quite at 75th percentile, but we do almost there, and we're expecting to see continued improvements with that. So again, more red than we like to see, more things under the 75th HEDIS percentile, lots of reasons for that, as well as lots of work ongoing to improve those. Next slide, please. Which then kind of goes through some of the different tactics and strategies and work in place. All these are measured, managed, being done sort of in highly reliable systems. We're changing the way we're organizing pediatric care, bringing more appointments available for well care visits, particularly during summer months, doing more immunization focused outreach by text message, which is new by that, developing schedules just for vaccinations, which have been pretty successful. Blood pressure is currently not a performance guarantee measure, though we would propose that we bring that back. We see actually national data showing increased blood pressure in all U.S. Residents during COVID, perhaps related to increased alcohol use, decreased physical activity in some populations, increased stress, decreased office visits for follow-up, lots of reasons for that. So we do have a series of tactics to improve blood pressure control, including more ways of doing blood pressure appointments, better ways of utilizing remote patient monitoring, which is kind of exciting for members who have the ability, the capacity, the interest to really self-manage, getting that data to the care teams in an automated kind of way. And then we're also doing work in some departments, including my own clinic at East Interstate, with a African-American blood pressure clinic run by a Black pharmacist who is doing outreach, then also seeing people whose blood pressure is not a goal. I was like, Chris, what is your magic? Is he doing a great job with my patients? He's like, well, it's really not magic. I talk to people, I spend the time, I help them understand why it's important. I use language they understand, and they see that, and that's what works. So I think there's not a lot of magic, but it is connecting with people, often in people that they may have a higher level of trust with, or really have more time for education and counseling. We are excited that we are sort of rolling out in 2023 a Black Center of Excellence, really to focus on clinical care for our Black and African American members that will be at Interstate. We are recruiting physicians and other staff for that, and there's a lot of interest among all my colleagues at East Interstate to do good for the community and be a great community partner. And we are We have lots of members on an advisory committee, and we also are working with community organizations that have been long-term partners in the community to help us get it right. And then finally, antidepressant management. Clearly, one of the fallouts of COVID that's ongoing is worsened behavioral health for really for our communities, and so we are providing more care for depression. We're diagnosing depression more, and there's more use of both therapy as well as medications. And it's a funny measure. It's really about prescription refills, which get muddled up if somebody starts on a higher dose and the dose is lowered. They may have extra medicines, so they don't fill their medicine prescription. Medicine can make it change. We know 30 to 40% of medicines, we don't hit it right on the first try. That changes and that messes up the metric as well. But anyway, no excuses there. We have a great depression management program. We have great pharmacists that work with depression, and work is ongoing to improve the HEDIS antidepressant medication management program, while we're also increasing screening for depression, other mental health disorders, and substance use disorders. On to the next slide, please. Thank you. So these next set of measures, this is 2019 and 2020, and the top few there are all around perinatal care, postpartum care, prenatal care, postpartum care, and developmental screening. And we were actually struggling with the developmental screening in 2019, got even worse in 2020. And then the lower three measures there are diabetes care, which we did see some lower is better for that measure, so we did see some deterioration. And you see a discrepancy between PEB and OEB in both years, with worse diabetes control. In PEB, we also have PEB is also a heavier population, which we know are more likely to progress with diabetes quicker and more likely to need interventions like insulin or weight loss surgery. And then you can see good performance with breast cancer screening. This is 2019 and 2020. We'll move to 2021, and you can see some changes here. In 2021, we saw improvement in the developmental screening, which had been lagging, and we were really focusing on that. And we really find consistently when we as an organization focus on something, we do see the measures move. We just can't focus on everything all the time. Our prenatal care and postpartum care really wasn't that affected by COVID. That care needed to happen. The teams were there. It was happening face-to-face. Some increased use of video visits for postpartum care, which has been popular before COVID. Some increased use of group treatments, some on video, some face-to-face for prenatal care, but really no gaps there. Diabetes care has lagged a little bit more, and something that we're concerned about. We're below the 75th HEDIS benchmark in both OEB and PEB. Certainly, it's all hands on deck right now to get people connected with diabetes care teams, get people in for lab checks who haven't been in for lab checks. And when someone hasn't had a lab check, this number will flag as abnormal or bad. So sometimes it's just bringing somebody in for a lab. Then really kind of doing our traditional diabetes care at Kaiser Permanente, where we're looking at our panels of patients by clinician. We're looking at our larger groups of patients by medical office. We're working with our diabetes care teams, focusing on the people who need it most. I think we've seen, in my observation, I think the data would support this, that some people with COVID, it was just a small change in their lifestyle, sometimes for the better, with more time for exercise and less commuting, but challenged populations had it worse with less ability to work from home, higher rates of developing COVID among them and their family member, more financial stressors, all those things, and more behavioral stressors, all of those which could impact diabetes care. I know, Catherine, if you want to make a comment about the bringing behavioral health into diabetes care, I know that's something that you're passionate about. You're on mute.
Yep. So we have a fantastic growing behavioral health program embedded within primary care, designed to allow for clinicians to provide warm handoffs. So, a patient is interested. I'm a primary care internist, by the way. So this is Keith and I. This is our day job, and if folks are interested in accessing that care, if we can give it to them now, they're much more apt to stay engaged versus having to wait. So that's the design, and it's been growing over the last several years. And folks who are emotionally struggling need the care for their emotional and mental health, but they also need the care because it's very hard to do all of the other things that you need to do to manage your chronic illnesses. So there's a lot of overlap there with diabetes. So we're trying to shore up the linkages there between, caring for members who have diabetes and caring for mental and emotional health.
Recognizing those two are often highly connected, and you can't do one without the other. Great. Next slide, please, Rose. And this again is just a list of our various tactics that we have in play. All are being intensified as we're seeing the numbers not come out the way we want them to come. We are seeing improvements in 2022 and expect other continued improvements. I would note there the last couple bullets relate to health equity consideration, are increased in global screening for associated determinants of health. Certainly those affect diabetes care directly, whether it's food, whether it's behavioral issues, whether it's transportation to office visits, whether it's the environments people live in, their ability to be physically active, really have a direct impact on diabetes. We're also very interested and doing work to improve diabetes control among Hispanic and Latinos. And in some of our service areas, we see significant variation there. It's interesting, it's not consistent among every service area that we have. We do have bilingual diabetes educators and diabetes pharmacists. We do have whole modules that operate not bilingually really, as Spanish is their main language, which provides even better cultural context, knowing that somebody from check-in to a medical assistant, blood pressure check, and med review to the physician all will be done in their preferred language. So again, that's important work and something that we are tracking, and we really support having OEB and the OHA use health equity measures as part of our ongoing performance management plans. Any questions so far? All right, we can go on to the third set of measurement guarantees, and this was 2019 and 2020, and where things were, definitely saw deterioration between 2019 and 2020, and difficult performance related to screening, brief intervention, and referral for treatment. That had a significant decline from 2019 to 2020, and is still not performing where we want it. We can go on to the next slide there. And you can see that really great performance with, even despite increased hospitalizations for mental health illness, we really redesigned our mental health post-hospitalization follow-up and transition to make sure individuals who had severe behavioral health issues that were in inpatient environments got that mental health afterwards. So we're doing quite well with those. Continued not great performance with SBIRT, which is a complicated topic. It's still important. We are proud of our addiction medicine integrated program. We have a commitment to make sure that people who need the treatment and want the treatment get it. We have a full range of access to prescribers for doing Suboxone treatment and medications for alcohol use disorders. We have a whole panoply of programs, from outpatient residential to individual counseling to group treatment to our Brookside outpatient residential program to help with that. There's still interest in primary care. We're doing an automated substance disorder screen that before any primary care visit, members get that screen. It's actually worked out pretty well to have a very brief, sensitive but not specific substance use and depression screen being sent electronically to individuals prior to primary care visit, and then if it's normal, they're sort of passed out of it. If it's abnormal, then we do more detailed screening when people are in the office. That's the kind of thing that's shifted. I mean, some of the things that we might be doing in primary care or the medical assistants might be doing, there's a limited amount of time and you have to decide what's most pressing. So it might be doing the PHQ-9, which is our depression screen, and following up on it. It might be doing more motivation entering about behavioral treatment. So some things like scheduling for a mammogram may not have happened, though we really need to do everything. So, yeah, I think that's comments there. We can go to the next slide. And kind of talked about that. I've always been interested in transitions in care, reducing readmission rates. I think hospital census has become more complicated. This is sort of national data, but we're seeing it Kaiser Permanente as well. Even for basic things like inpatient removal of gallbladder or a hysterectomy, people are in the hospital longer. They're sicker when they come in for even routine hospitalizations, and obviously sicker when they come in for non-routine or emergent hospitalizations. Catherine, want to make any comments about any of those metrics?
I suspect that part of our performance challenges with the brief intervention and referral to treatment is just the ability to capture the data. We continue to work with our care teams on the nuts and bolts of that, but I think sometimes when you're in a busy clinic, it's hard to remember to use the right code and things, and so we'll continue to shore up our efforts around that. But it's also been, I think, more challenging to screen with the sort of virtual versus in-person and the staffing challenges that I think are universal. So I'm hopeful. A lot of the things that we've done this year are refocusing our care teams on relationships. That will shore up efficiency, and I think those I'm hopeful we'll see some improvement there.
Great, thanks. And remember, we're following all this data on a monthly basis for OWEB members, PEB members, all of our members. When things are working, we continue. When things are not working, we try something else. So it's really ongoing quality improvement work everywhere throughout the system. Next slide, please. And this is, again, 2019 and 2020, the last series of measures there. I don't know, we can kind of go to the next slide, look at 2021. And you can see the improvement in the follow-up after mental illness at really now working at pretty high levels with that. That's definite system change. Good follow-up after ED visits for substance use disorders with a book of business commercial rate because the numbers were too low for OWEB and PEB. And then cigarette smoking prevalence, which is definitely below CCO benchmarks. And it's historically always higher for PEB than OWEB. Great, next slide, please. So this is just a list of other things going on that we didn't comment on otherwise. Mammography, cervical cancer screening, OBGYN RNs are scheduling visits for this. That's actually standard in most countries in the world and cost effective and actually a patient satisfier as well. Ongoing, our dental program, who both OWEB and PEB members have access to, are very proud of their work as helping members get their care gaps and preventive care needs scheduled or even filled at the visits. Things like flu shots get done while someone's in the dental chair, along with blood pressure check visits. And obviously using digital tools and centralized outreach, but I think we're finding that although central outreach is great and can be very efficient and can apply technology, that the face-to-face, individualized, personalized contact, well, mask to mask, face-to-face in the doctor's office is still really important from both medical assistants who often kind of start the conversations and then clinicians who end the conversations and getting members, their needs understood, the importance of the why, and the getting the services delivered to them. So with that, Catherine, do you want to add anything else?
Yeah, I'd say the centralized outreach is, newish for us in the last couple of years, and I suspect we'll find balance ultimately amongst that, you know, individualized approach. Some people I think are benefit better from that, and some people just want the link that they can click on to get the thing done. So I'll be excited to see how that plays out.
And again, people resources are constrained more than ever. I mean, some of the central outreach team got pulled to do COVID vaccination or COVID swabbing. So that's just been the challenge that we've been, as everybody else in schools and in public settings have been dealing with. It's not been perfect, and it's been a zero-sum game. And some things we had to prioritize, and some things fell down. But I think in time we'll be able to be more efficient and get those back. Last slide that we have, we were asked to provide recommendations for future performance guarantees, and there are a few things that we did recommend. One, we do think blood pressure control is so important right now. We are seeing deterioration in blood pressure levels in the community and in our members. So we do think that that's something that should be brought back into the contract. Cervical cancer screening still is important as people are coming into clinic less or maybe less engaged with the healthcare. That's something that we're worried will slip. It's a 5-year interval for screening when both PAP and HPV are done at the same time. So those numbers aren't reducing as fast as some of the other preventive metrics, but the way we projected it, we're a little bit concerned, and we are doing more efforts, and would love to share our work and show our performance improvements with OEB and PEB, and then ongoing work for race and ethnicity, looking for disparities and managing and mitigating those disparities, which is challenging, important, but really connects to the why that we do the work that we do. And finally, there's different HEDIS metrics for depression screening and follow-up being used at CCOs versus HEDIS. We think it would be better to be consistent, and the HEDIS metric we think is more clear, easier to measure, and a better metric to use. So we would advocate, if we have any influence on the teams at OHA and the metrics committee, to advocate for that. Thank you. We
Keith?
are available for questions. Yeah.
Yeah. The one that I was surprised with, and I'm interested in seeing what Kaiser Permanente is doing, is the statin therapy for diabetics, which seems to be at kind of stuck around 2/3. And I don't know if it's rebounded in 2022, but that one I was surprised with.
Yeah, me too. And I was thinking about it this morning. I was kind of trying to look through our playbooks and see what we had. And I couldn't find it. If Catherine, if you have any, I have some ideas based on my clinical experience. But if Catherine has a little better science on that, I would defer to her.
I don't have any science. I think that it's even before COVID, we felt like we had sort of reached a steady state that we were trying all sorts of things to try to push forward in terms of different types of outreach and education. We have a pharmacy team who watches adherence rates closely. And our clinicians, at every opportunity are having these conversations. And so, again, I think that with really trying to refocus on continuity and trust, those conversations are a little easier to move the needle with those ongoing established relationships. And then I think that ongoing efforts around outreach, I would like to continue to try to do some of that work.
Yeah, go ahead, Tom.
I was just going to say it's not that you're an outlier. I have the for a Kaiser Permanente OEB in 2021 it was 67.5. For PEB it was 67.3. For MODA the CCM was 65.9. For PPO was 60.7. For Providence Health Plan, for their choice, it was 65.2, and for the PPO, 61.8. So it just seems I'm far enough out of clinical practice that I don't know the importance of this. Back in the day, the idea was that we were looking at diabetes as cardiovascular disease, associated with high blood sugars, and statins just become such a critical component of decreasing cardiovascular risk. So if these numbers are stable and difficult to budge, that may be something that we look to as a statewide intervention initiative, along with, I agree entirely around your discussion around blood pressure control.
Yeah, and I mean Medicare, it is fundamentally important. The data has only gotten stronger for statin therapy and reducing risk of cardiovascular events. So it's anything we can do to educate our population and reinforce that message.
Okay, all right. So that was the other thing that I did was, for each of the plans, I tried to get a sense of up and down and stable. My guess was going into it that 2021, using the HEDIS, the 2021 would still be severely impacted by COVID, or by the impact of the pandemic in terms of healthcare delivery. And it was interesting for OEB, 9 of the metrics had improved, 12 had declined, and 2 were stable. For Kaiser Permanente's PEB population, 12 had improved and 11 had declined. So that was I thought, interesting data. And my hope, of course, in 2022 is that the number that are in the decline compared to 2019 will drop again. I think we've already seen some of those numbers.
I agree with that, Tom.
Okay.
Thank you.
Any other comments from members of SEOW? Andrea or Greg, do you have any questions or thoughts when you look at PEB data? Or
no, it's just this is Greg. No, it's very interesting to look at some of the figures between the two. So it's kind of really kind of cool to see how it the differences, but yet a lot of similarities.
Yeah, and so Greg, thank you. This last conversation around looking at 3 different health plans, 5 different options, the choice and PPO for Providence Health Plan, the coordinated care model, and the PPO for MODA, and then Kaiser Permanente across the 2 different entities, OEB and PEB, looking for commonalities, looking for things that where there's a consistent issue, where we know it makes a difference in terms of health outcome. That's the importance of being able to mine this data, and it's a great example of what SEOW has been about over time. Okay, well, thank you very much. Any kind of concluding comments? You've given us your future recommendations. We'll for sure take that into account as we look at putting together what's going to be in the measurement.
Great. No further comments, and thank you.
Okay. And anything else from SEOW members? Okay. No. It is now 10:23. We have both MODA and Providence Health Plan going to be going over theirs. We've been going for almost an hour and a half, and Glenn had put in our break 40 minutes from now. I'm going to suggest that we take our break now and reconvene at 10:35, and that way people can deal with the coffee they've been drinking and things like that. So it is now, as I say, I have a 10:24 on my computer. We will start again at 10:35. Nathan, hopefully that gives you an additional 10 minutes to get everything perfect. And It'll give me time to do a couple other little calculations. So I'm going to put it on hold now, and we'll reconvene, as they say, in 10 minutes.
Sounds great. Thanks, Tom.
Rose, are you there?
Yes, sir.
For the presentation for the board, for the SEOW presentation, there are 3 slides from the OEB PEB 101 that I think would be helpful to have.
Okay.
One was the aligned characteristics. The other one was the unique characteristics. And then the third one is the key takeaways.
Okay.
The rest of it, I'll just give a verbal report from the, so we won't get into the weeds of the quality performance guarantee part. But
Okay.
thank you.
You bet.
Okay, it is now 10:35, and we are going to restart the SEOW meeting, and we have Nathan Trenholm from MODA, who's going to be describing OEB and PEB quality metrics. So Nathan, you're on.
All right, thanks, Tom. And I'm going to be actually joined today by Erica. She's going to chime in on some of the Moda 360 work that's happening. She's definitely an expert in that. So we'll be hearing from her on that a little bit in a minute. But I guess for those of you that haven't met me yet, my name is Nathan Trenholm. I'm the Senior Manager of Quality and Informatics here at Moda Health, and I've been here for about 12 years. My background is really in public health with a focus on epidemiology and biostatistics. So kind of essentially I'm a data guy, which is I'm really excited today to be talking to you guys about the performance and our quality metrics. And this presentation is really data heavy. So one of the things I did want to just kind of put out there for all of you guys, I mean, this is really intended for you guys to be kind of informative for you. So I really want to make sure that if you get any questions answered, so please feel free to kind of interrupt and chime in throughout the presentation. Really want to make sure that you guys are getting kind of what you're hoping to learn out of this rather than me just throwing a whole bunch of numbers at you. So with that said, can we go to the next slide, please? All right, so our basic plan for today, we're going to run through the performance on our 2021 quality metrics for the CCM, OEB CCM, the OEB PPO, and then new for this year in this format is the PEB CCM. So just lots and lots of data kind of throwing at you. And we're going to talk a little bit about some of the trends that we're seeing and some of the comparisons to benchmarks. One of the things that Dr. Stiltsville really, or I'm sorry, Dr. Bachman really kind of highlighted in his discussion was around how COVID's impact is really kind of hitting everything a little bit differently. And so I really want to encourage us to think about benchmarks in particular as COVID had a lot of regional impacts. And as we kind of look at where those comparison groups are, each measure is going to have some really different and kind of unique activities that's happening. So we'll try to talk through some of those nuances as we go through. But just wanted to kind of put that out there that some of the benchmarks are still doing kind of weird things as well. And so that's something that it's a great comparison point, but it's maybe not necessarily something we want to get kind of overly hung up on. And then we're also definitely going to talk through a little bit about some of our quality improvement efforts and where we're targeting on our focus and really driving quality improvement going forward. Then rounding out with some suggestions and considerations for some future years. Can we go to the next slide, please? All right. COVID impact. So we presented and had a lot of discussion about this overall. And one of the things that we really see is, COVID just doesn't have a static, flat impact. We're seeing a lot of utilization impacts based on COVID activity in your specific region. So we get a strong spike in COVID activity in the Portland metro area, utilization crashes. That doesn't necessarily impact some of the more rural counties. So then, as COVID activity spike out in rural counties, we see, corresponding changes in utilization. So there's not really one static impact when we talk about and think about COVID. And I'd say the other thing that really I would encourage us to be thinking about is the long-term impact. A lot of these measures have 3 and 5 and even 10-year look-backs that have been impacted by COVID activity. And we're still not even back to some of the kind of pre-COVID levels on a lot of these performance metrics and just from a utilization standpoint. So we're seeing a lot of continued impact and it's going to be kind of playing across different measures in different ways. And one of the things that I think is really encouraging is that we are seeing an increase in performance in 2021 relative to 2020, almost across the board. So we did see some decrease in some of the mental health follow-up measures. I think we'll talk a little bit about that as we get to those specific measures. But I think one of the things that I wanted to highlight here is that telehealth for mental health in particular is really exploding. We're seeing a lot of increased utilization in telehealth. But a lot of the mental health measures are really looking at some pretty challenging populations. So those may not necessarily be the easiest to impact with the telehealth solution. So I think that's where we're seeing a little bit of a divergence in some of the mental health performance. The other one that we're seeing is some of the utilization measures are rebounding and are becoming kind of a little bit more tied to our overall kind of COVID performance rather than just a flat suppression of utilization across the board. All right, can we go to the next slide, please? And the next one as well. So we're going to start off with talking about the OEB CCM performance. The way these slides are all structured, they're all going to be pretty similar in that we have the measures kind of, as Dr. Bachman mentioned, we're in the order that they are in the contract. So they're not necessarily grouped in necessarily functional categories. We've got a 3-year trend performance on the left-hand side for each of the measures. So this is the OEB CCM performance specifically. And then on the right-hand side, we have both the 75th and then the 90th percentile benchmarks. So kind of giving us 2 different really looks at our comparison points. So the first one is that child and adolescent welfare visits. This is a measure that was new in 2019 in that it basically collapsed several different measures together that are all looking at different age bands. So we're looking now between ages of 3 to 21. So it's a really, really broad age band. really challenging, different challenges within that population in terms of getting those WellCare visit utilization. However, we do see year over year increased utilization there, which is fantastic. I think this is one that we're really seeing a lot of engagement from the providers around, we just need to get people in the door. We're seeing shifts to telehealth. Telehealth is now part of that measure. In 2019, it was not, but in 2020 and 2021, it is. So I think we're also seeing some of the lift available through that telehealth intervention. We're still not at that 75th percentile, so this is definitely one of the measures that we are actively really pushing on and really see this as kind of a gateway to a lot of the other childhood kind of readiness measures. So thinking about the immunization measures, the appropriate screening measures, development of screening measures, et cetera, are really geared towards if they've actually come in and engage and have a visit. So I think we're seeing some really great trends there, and I really hope to see that continue. The next measure is the ED utilization measure. So this one, technically NCQA changed the technical specifications on it, and so we did see a little bit of a shift in how the measure is calculated, but for all intents and purposes, it remains basically the same measure. Now we're removing some of the outliers, and it's more of a risk-based measure. So the observed to expected ratio is what NCQA provides the benchmarks on, which is really just a risk-adjusted look at how many visits are you having versus how many are you expected to have based on the risk of your population. And this is an area where the CCM performs particularly well. You can see that our performance for that risk-adjusted measure is the 0.6883, which is just shy of that 90th percentile. But I think overall, really fantastic performance. One call out that I did have on that was that the overall ED utilization did go up a little bit from 2020 to 2021. That is something that we are seeing pretty much across the board. As COVID is starting to have a little bit less of an impact. We're definitely seeing more COVID fatigue in terms of precautions. Then more people are just using the ED. So that's something we're definitely keeping an eye on. But at this point, utilization is still really low relative to a lot of other areas, and so we're seeing that as really still continuing to be a strength. Childhood immunization status. So this is one where we actually saw a little bit of a decline relative to the 2020 performance. 2020 was kind of a little bit of a weird year. I'm not entirely sure what the driver was we saw just incredibly strong performance here. And so one of the things that I would just keep in mind for this is a 2-year measure, and the childhood immunization schedule is very complex. So for kids that are in the 2021 measure, a lot of the activities actually needed to happen in 2020. And that's once you start to fall a little behind in that immunization schedule, it's really hard to get caught back up. So I think that we're seeing a lot of the impact of the actual activity within 2020 reflected in our 2021 rate. But you can see we're still well above that 75th percentile. So that's actually an area that we're seeing as a continued strength for OEB, and particularly for the CCM. So that's some truly outstanding performance. Some of the other measures, so colorectal cancer screening, actually a little bit of a decline in 2020, and then we're starting to come back up a little bit in 2021. But again, we're pretty far from the 2019 kind of pre-pandemic performance, and that's another area that's just heavily impacted by utilization trends within primarily from COVID. So we are seeing some improvement on that, but I think this is an area where we're going to continue to focus over the next 10 years, really. As we kind of really readjust and think about how we get members in for these colorectal cancer screenings, particularly for the CCM population. The primary modality for meeting this measure was the colonoscopy, which is kind of the gold standard in care, and it is good for 10 years. However, we did see some significant reductions in colonoscopy utilization, in particular in 2020. So that's going to have a lingering effect for quite some time. The antidepressant medication management. So I think this is an area where we saw a little bit of a surprising trend from my perspective as we think about mental health utilization in general. We saw a lot of challenges in those mental health utilization measures. But for this particular measure, this is an area where I think we're seeing some of the impacts of telehealth and a lot of focus around medication management. So really helping identify members, getting them into treatment, and then making sure that they're maintaining and managing that treatment in an ongoing basis. So we saw some really strong performance in both the acute phase, which is really looking for that kind of newly diagnosed depression and newly started medication, and then along with that continuation phase, which basically follows them for the next 9 months, making sure that they're adhering to that therapy regimen.
Nathan, did I miss your comments on high blood pressure?
No, I skipped past that one. I was starting to feel like I was just kind of talking a lot of detail on the slides here, but the controlling high blood pressure is definitely one that we did see a little bit of an increase in performance from 2020 to 2021. But as Dr. Bachman mentioned, this is heavily driven by office visits. And we're still working, and I'll talk a little bit more about this further down around making sure we have access to that data. But it is definitely one that is a continued focus, and is something that we are working on. But I think that there's some data gaps there as well as some utilization gaps.
Okay.
All right. Can we go to the next slide, please? All right. I'll kind of move a little bit more quickly through most of these measures. The couple that I did want to call out was the timeliness of prenatal care and the timeliness of postpartum care. We did see some very slight changes in those, particularly in the prenatal care, but overall really strong performance. And so this is an area where I think that we're really looking for that appropriate utilization, and we are above the 75th percentile in both of those cases. And for the postpartum care, we're actually above the 90th percentile by a fairly good margin. So I think this is an indication that when members actually really need some of these services, they are able to make sure that they are getting them. And so that's something that I thought was particularly encouraging. One other comment that I had was around the diabetes care. And so in this case, we saw so this is a measure where lower is better. So this is looking for an A1C poor control. So the A1C needs to be less than 9%. And so we're seeing a pretty strong performance here on the CCM side and an improvement year over year from 2020. And is really around kind of that effective diabetes management. That's been an area of focus for MODA for the past several years. We've been working on getting a lot of programs, a lot of member support, really spun up for our diabetic care, and also really focusing around kind of telehealth management and working with our members in kind of a remote way to do that. So that was something that I thought was particularly encouraging, is that we're seeing some really good results out of that process. All right, let's move on to the next one. Thank you. All right, so a couple of things that I wanted to call out on this slide. So the first one is the weight management or weight assessment counseling for children and adolescents. There's 3 different submeasures for this particular measure. One is just the BMI percentile. So is the BMI recorded and evaluated based on the overall kind of distribution for pediatric patients. The next one is counseling for nutrition, and then the last one is counseling for physical activity. One thing that we're still kind of working through some of the disconnect with this measure as it relates to the wellness screening measure. But you can see that the performance in this measure, at 75%, is quite a bit stronger than the 50-ish% of members that are getting in for that wellness visit. So we think there's really some kind of documentation questions that are really coming on that is driving both these measures as well as the wellness measures. Kids are getting in, they're having services, and we're really working with the provider community to make sure that we're documenting that these specific things happened in a way that we're kind of meeting the criteria for the measure. NCQA is pretty specific in how they want this data presented. And so that's been just a challenge with providers. We're asking a lot from them, particularly in the pandemic, and the nuances of how they're focused on documenting a counseling for nutrition visit has just not been their top priority. So it's something that we're definitely working towards, but we believe that's more of a documentation issue than a performance issue. The other one that I wanted to call out was the all-cause readmission. So we are seeing a very low readmission rate. So that's that 4.82%, which is fantastic. And then when we look at that observed to expected ratio, in this case for the CCM measure, we're just a little bit above that 75th percentile. So this is the lower numbers for this is better, indicating that you're kind of performing better than the expected based on your risk profile. But I think one of the takeaways from my perspective is that the overall number of readmissions is down. The absolute readmission rate is quite a bit lower. So I think that, relative to the prior year performance, that's a significant improvement. So that was something that I definitely wanted to call out. The last 2 things on this slide was really the follow-up after follow-up after ED visits for either mental illness and alcohol and drug dependence. Both of those measures saw some declines, and I think that is really kind of tied to the challenges with that specific population and their ability to really engage in a telehealth solution. Is where we have a lot of solutions available, but for that's a particularly challenging population to really work with there. And the in-person support for that has been a challenge, I think, across the entire United States healthcare system. So that's where we see a little bit of a decline in performance. And we also saw similar declines in the actual percentiles from NCQA. So I think that's something that we're, as a nation, really kind of struggling with, but definitely a continued focus in terms of how we connect and manage some of the care within the CCM. All right, and let's go on to the next slide. So now we're going to shift and talk exact same thing through PEB. So I'm sorry, through the PPO population. Very similar trends. Excuse me, on the PPO side. One new challenge, I think, for this year is that we've seen enough of a shift in terms of membership base from the PPO plan into the CCM plan that we're starting to have some challenges in reporting some of these measures specifically for the PPO. So we're starting to run into some denominator issues. So we are reporting more of the commercial book of business. And I tried to make sure that we had some trends available there. So like for the child immunization combo 3, we can see that's a commercial book of business trend rather than the specific OEB PPO performance. That's really just driven by the membership shift. So I don't think there's any particular concerns with the actual overall performance with it as it relates to that. However, just something that I wanted to call out as we're going to kind of continue to see that as those members shift across. The ED utilization is actually quite a bit lower on the PPO side than it is on the CCM side. So that was something that I think there's a little bit of a different risk profile for those members, which is, I think, really what's driving this ED utilization difference. But again, that's something that we see significant, that continues to be a high performing measure from the benchmark standpoint on the PPO side. Similar trends for colorectal, controlling blood pressure, and antidepressant medication management. So we'll move on past those if there's no questions. All right, let's go to the next slide, please. All right, so this one, I think the big change on this slide is really around the diabetes care, the A1C control. So as we talked about that on the CCM side, we saw some significant improvements in that performance. On the PPO side, this is, I think, primarily driven by a relatively low denominator. So I think we had like 32-ish members in this specific measure. And so we're just seeing, I think, some of the impact of that slightly unstable denominator size. This is absolutely an area where we continue to focus. So I think this is maybe just an aberration in some of our overall performance, but it's absolutely something that we are looking at, how we can really specifically target some of these PPO members to make sure that overall rate comes back down again. All right, Nathan, let's move on. Oh, yes.
I think that it's we had seen the numbers drop in the PPO significantly once you made the change to the CCM 0.2. Do you maybe Erica can, when she comes on, can talk about what the numbers are in terms of membership that's in CCM versus PPO? That would be helpful.
Yeah, absolutely. I don't think we have any slides or anything that specifically addresses that, but we can definitely talk to that at least at a high level. And if there's
high level is fine. Yeah.
We can find that and pull that out.
That's great. Thank you.
Absolutely. Yeah. All right. And let's go to the next slide, please. So again, very, very similar kind of patterns in performance here. The all-cause readmission did drop down a little bit, and it's not quite as low, the overall readmission rate or the observed to expected rate for the PPO side. I think that's still a fairly good overall performance on that readmission rate, and it's trending in the right direction. So I think that's something that we're particularly pleased with. And very much challenged with the follow-up after ED utilization here. Again, those are going to be relatively low numbers. I think we're right on that cusp between the kind of 25 to 35 membership profile. So we are kind of bouncing back and forth between the commercial business book of business and the OWEB PPO specific rates. But I think similar to the CCM side, this is an area where we see a lot of opportunity to really kind of better engage and manage these patients. All right, so let's go on to the next slide. I think we're shifting over to the PEB performance. So one of the things I wanted to call out is that the PEB the PEB measure list was a little bit different for this year than in the OWEB list. So you are going to see a few differences in the specific measures, and that is something that in future years that is fixed. So we do have the exact same list of measures, which is, I think, really fantastic. One of the things that is really challenging for us as a health plan is trying to manage different sets of measures for different populations. So having that consistency, I think, is really important. And I was really glad to see that we were able to get those back aligned again. I think that's really helps streamline our quality improvement strategy and overall process. So one of the measures that's on the PEB side that's not on the OWEB side is the adolescent immunization status combination 2. So this is the measure that includes the HPV as well as the DTaP and MMR immunizations. This is one where we saw, again, similar to the combo 3, we're seeing some slight improvements in some overall performance as we saw on the OWEB side. But again, this is something that is going to have a lasting impact. This is looking at members who turn 13. And so those immunizations can happen anytime, usually between the ages of 10 to 13. And so, as members, that 2020 experience period is going to have that kind of shadow impact for the next couple of years as this kind of runs out. So it is an area where we definitely see some opportunity for improvement. Very similar trends compared to the OWEB population overall. However, with the PEB side, I think we saw this a little bit in the kind of 101 presentation this morning, in that the PEB members tend to have a slightly higher risk profile and are slightly, there's just a little bit of difference to the overall population, and we see that reflected in some of the performance. So the breast cancer screening in particular is an area where actually all of the cancer screenings, we see just slightly lower performance on the PEB side than we do on the OWEB side. But again, we're right at or exceeding those 75th percentile benchmarks for those preventive services measures. So overall performance is fairly strong. All right, let's move on to the next slide, please. All right, so again, this one, the diabetes control measure is very, very strong performance. So this is something that I think that we've really implemented a lot of these diabetic management programs kind of across the board, and we are seeing a lot of those telehealth solutions being particularly effective in helping patients manage some of their diabetic needs. However, there's some opportunity in some of the statin therapies, which I'll talk about some of the interventions we have kind of coming on for that in the next couple of slides. But I think there's medication adherence is a continuing challenge, and so really thinking about how we engage in the membership in their own health is particularly important, and is something that we do see some opportunity for in the statin measures as well as the preventive service measures. Right. Let's move on to the next slide, please. All right, so this measure actually, so the BMI, the weight assessment measures for children, we are seeing a little bit stronger performance on the PEB side than we saw on the OWEB side. But I think, again, this is getting a little bit closer to the true performance, but we still believe there's some documentation issues to really address there, and are really focusing on kind of closing that gap. And then the other measure that I wanted to talk to you just a little bit was the meaningful language access to culturally responsive healthcare services. So this is an OHA measure that PEB requested we take a look at. And one of the things that really kind of came out to light with this was that the way that we're kind of engaging our membership is very different across different lines of business. So our CCO side has a lot of provider engagement that we're just not seeing on the commercial side to the same degree. And so that's an area where we're definitely looking at increasing. And you'll see that as I talk about the next slide is how we engage our provider community to really help kind of partner and think about how we can make sure we're providing these services. But I think that the the data sources for this measure are not quite the ones that we're seeing on the commercial side. So it was a little bit of a challenge for us to use the exact same ONJ survey. But I think this was still a useful exercise for us to really be thinking about, how are we making sure that we're providing those culturally responsive and language access services. And it's something that we have a really strong telehealth program to kind of support this, so that translators and interpreters are available kind of as needed. So that's something that we do provide some tools and services for, but really it's helping make sure that those are kind of connected and engaged in our provider community as well. All right, and let's move on to the next slide. And so this is, we have kind of a couple different focuses or ways that we're focusing our thoughts around quality improvement strategies. So one is really looking at kind of our overall global improvement process. So things that are going to hit multiple measures, and how we think about how we can kind of create a better environment for providers and members to engage in quality. And then we have a number of really kind of point solution efforts that are really targeted towards specific measures and specific activities for improving health. So the first thing we're really looking at, and this is really a trend across all of our lines of business, is really looking at how do we increase that provider engagement. When we went into COVID, providers were really just reacting to how do I move on to a telehealth modality? How do we really address a lot of the challenges with COVID that are really being presented? And we're starting to be able to kind of get a little bit past that, and the providers are seeing a little bit more capacity for how we can kind of engage and partner with health plans and maybe in new ways. So we are looking at a lot more communication with our providers. So we've got a really strong provider newsletter, and really looking for how can we help providers understand what it is that we're looking for as a health plan. And we provide a lot of education for providers through our provider portal, through our continuing education, where we actually go out and meet with providers and engage with them to help them just educate them about what it is that we're asking for, why we're asking for some of this data, and why we're asking that to kind of be a little bit more of a partner with them in terms of the overall process for members' health. And so that's something that's been really well received, and it helps providers understand a little bit more context about why we're trying to kind of push these initiatives, which has been really nice. And then one of the other areas that has been a significant focus for MODA is the provider data sharing. So this is our provider data exchange, and really looking at how we can get a lot of this data in a prospective fashion from our providers to really drive quality improvement processes, rather than the kind of more traditional retrospective chart review process. And so this is an area where we've been onboarding providers over the last several years into a kind of a more real-time process. As of last week, we were able to get, we have at least some data points on 92% of the OEB membership, and we have at least some data points on 83% of the PEB membership. So we actually are seeing really strong coverage in that process. One of the things that is a little bit misleading in terms of we have at least one data element for those members. We know that we're getting a lot of kind of somewhat jumbled data from providers. So our next step is really looking at how we can really improve the overall quality of that data, as well as continue to expand our overall reach. So making sure that we're continuing to onboard additional providers, but then really starting to kind of round back with providers that have been submitting that data to really help them, help us identify where are there opportunities to improve. So things like blood pressure values, there's just formatting issues in how they're submitting and transmitting that data that makes it challenging for us to interpret it. So working with providers to kind of clean up the way that they're sending that data, so that we can make better use of it, and then start plugging that data back into feedback loops. So we're sending it out to providers and their monthly provider reports. We're also feeding that to our clinical management teams. It's feeding into MODA 360, so the care navigators have that activity kind of that data at their fingertips. And so we're starting to have a lot better picture around the actual performance on those specific measures that require some of that clinical data that we historically have had a really hard time getting. So we're making a lot of really good progress in that space. I think that we have a long ways to go, but I'm really encouraged to be able to report just those kind of basic stats around the overall percent of membership that we have at least one data point on. Is definitely been a metric that we've been watching for some time and seen some really positive growth. All right, and let's move on to the next slide. So the other kind of main focus we have for our quality improvement strategy is really member engagement. So we're really looking at how we can engage members across a lot of different modalities. So we're seeing a lot bigger emphasis on emails. This year, we're trying to really kind of connect and engage in that telehealth solutions and really kind of drive members towards electronic utilization. We found that particularly for OEB and PEB members, they're busy during the day. They don't want to have to answer their phone. And the mail kind of traditional postcard and mail-based outreach only has some limited impact. So as we're trying to really look at how we can kind of augment all of those different modalities together. Sending an email followed by a letter followed by an actual phone outreach has been able to have a lot more impact and kind of remind members about some of their health needs that we weren't really able to do in previous years. And then we have a lot of different point solutions. So we're making a lot of efforts, particularly around some of the preventive services, where we've seen some of that utilization challenges. So colorectal cancer screens, breast cancer screens, the child wellness visits, just really trying to make it easy for members to know, oh yeah, that's past due. I haven't really been thinking about that for the last 3 or 5 years, and needed to make sure make it easy for them to get that scheduled. So a lot of kind of member education, helping them understand, why is it important, and then presenting resources for how to actually kind of engage and connect with the provider community. Right, and let's move on to the next slide. I think we're transitioning to Erica. Oh, so sorry, I had one more. One other measure incentive that I wanted to, yeah, let's go to the next slide, please. The pharmacy activities. So we are looking at, we work with a partner called Magellan. So this is a group of primarily pharmacists that are really working with both our members and our providers to really educate them about the importance of their medications, and specifically looking at both new starts for things like statin use, but also medication adherence. So making sure that our members are kind of engaging with their pharmacy teams to make sure that they have a good understanding about what their medications do, and that they really understand the importance of kind of continuing to adhere to those medications as they've been prescribed. So this is a program that's been particularly well received, and we get a lot of engagement from both members and providers around just kind of the importance of medication management. All right, and with that, I think I'll turn it over to Erica to talk a little bit about Moto 360.
Great, thanks, Nathan.
Erica,
yeah.
You've got, can you do it in 5 minutes?
I sure can, yes.
Great, thanks.
Yeah, thanks. And Dr. Siltabo, to answer your question, currently we have of a total 100,400 members, 78,118 of them, so about 77% are in our CCM plan. And just a little over 22,000 are in the non-CCM plan.
Great, thank you.
Mm-hmm. And so Nathan talked to you about the different measures and how we're performing, as well as some initiatives that we use and employ to try and influence those measures. And one of the areas that is newer in how we really work to increase those measures is Moto 360. So one of the avenues we have with Moto 360 are what we call care reminders. So every time a member logs into their member dashboard, on their home screen up in the upper right-hand corner, they're going to see something similar to this if they have care reminders that are overdue. So these care reminders are all tied to the performance guarantees that we have in our PEB and OEB contracts. So if a member like this one is overdue on statin therapy, that's going to show up in their member dashboard. So they can click on it, and it'll take them, it'll have a little pop-up that gives them more information about what that reminder is. And then they can also contact a health navigator through the phone by clicking on the contact health navigator, or they can click the live chat and chat with the health navigator. And the navigator can just answer questions they might have about the care reminder, or they can help connect them to a provider to be able to help close that care reminder. So Rose, next slide. So this is just a snapshot of what the engagement with those care reminders has looked like so far. You'll see that a lot of members are clicking that they've already done this. That may be that they have already done it and our claims data just hasn't updated yet. But I think members are also using that just to clear the alert when they see it. The one that we get the most engagement with is the visit a dentist or yearly dental exam. So if a member hasn't had a visit with the dentist in the last 12 months, then they will get this care reminder. And that is the one that members are engaging with the most right now. Next slide, Rose. So we will be launching a new member dashboard experience for our MODA 360 members in early 2023. And so our care reminders are still going to be a part of that new member experience, but it's going to look a little bit different. So when members come into the dashboard, instead of having a little box in the upper right-hand corner, they're going to see MODA 360 in 2 different places. One, they're going to see it down here on this bottom tile thing over on the right-hand side. And then also it'll be a tile on the home screen. And if members have overdue care alerts, there will be a little number, like if they had 3 alerts, there'll be a little red number 3. And so they can click on that and it's going to take them to this screen and it's going to list all of their care reminders right here. And then they can click on it. And this is an example of what that's going to look like, just a little bit of a description of the care reminder. And then also gives them the opportunity to call. So they can call right there if they're using their phone or to chat with the health navigator as well. So we just continue to keep pushing those out to our members. Next slide, please, Rose. Our navigator and advocate teams, our care teams, also have these care reminders on the consoles that they're using. So when they're working with our members, they can see all of the different care reminders that we have. It'll show them, you know, if it's green, then the member's caught up on that care reminder. But if it's red, like this example here for the cervical cancer screening, then it'll show that it's overdue. And it will give them just a little bit more information. For example, how many days overdue it is, when was the last service for that reminder. And so that our care teams can talk with members and help close those gaps as they're working with them over the phone. And if a member clears this reminder in the member dashboard, it's also going to clear it for our care teams too. So they'll be able to see if a member has said, I've done this, or please snooze this alert, so that we're not also talking to a member about a care alert that they've already said, you know, I've taken care of this. Next slide, please, Rose. All right, and I'll go over this really quick. As our care teams are working with our members on closing these care alerts, we know that social determinants of health also impact a member's ability, oftentimes, to be able to close some care alerts. This is just an example of some of the information that our care teams have when they're working with our members on health context. And this is just a snapshot that, you know, says their preferred name, their preferred language, and then if we have information on their primary method of transit or some other indicators, that'll show up on this summary page as well. Next slide, Rose. Our care teams also, as they're working with the members to close these care alerts, they might receive information from the member. So in their consoles that they're working on, they have forms to be able to enter in the real D, which is race, ethnicity, language, and disability, and the SOGI, which is the sexual orientation, gender identity. And those are both OHA forms. So the navigators and the care teams will actually collect that information from members as appropriate and enter it into these forms. Another form they have is the CMS Accountable Health Community Survey. And that's where they're really collecting that information on social determinants of health. And so if they're talking to a member about closing a gap in care and transportation is an issue, they can help connect that member to resources to help close that transportation gap. They also enter that into that survey form in their console, and it will update our health context model. And then we'll also show there, so anytime one of our care teams or navigators brings that member up and they're working with that member, they can see that that determinant of transportation has been identified for that member. All right, let's go ahead a couple slides, Rose. One more. Yep, that's the CMS survey, and then one more slide. All right, and then just wanted to provide an example of how our case managers are working with members to close those gaps in care. So we do use data to target communications and outreach to our members. So for example, our case managers are utilizing real-time admit and discharge platform to screen patients daily, and then they assign them to a case manager for outreach. And our health context score, which is that social determinants of health score, it informs that outreach and will prioritize members based off of their vulnerability score. When a case manager reaches out to a member, they just work with them to help them understand their discharge instructions. So anything on medications, activity, if there's any diet restrictions, when to call providers or when they should really be following up with a provider. They'll also just ensure that they have the supplies and services in place that they need and make sure that they're able to obtain their prescriptions, and also can give some instruction on those prescriptions as well. The case manager will also review for other gaps in care and then help close those gaps in care or connect the member to the resources that they need for that. And then they'll continue to follow up with that patient for approximately 4 weeks. And they're following up with that person about 2 to 3 times a week, but it really depends on the person and their situation. Sometimes when they're working with a member, they have a care person in place and maybe they don't really need a lot of resources or assistance from us. And so we will not be contacting them 3 times a week. But for those members that do need that outreach and assistance, then we are reaching out to them more often and for an extended period of time. All right, next slide, please. All right, I'm going to pass this back over to Nathan to talk about some of our recommendations.
All right, thank you, Erica, and I'll keep it super brief. I know we're trying to move through in the timing, but I think the basic recommendations that we have are really around kind of aligning to 3 tenets. So one is to consistency. There's a lot of activity that happens to really spin up quality metric improvement activities. And so we work with our members, we work with our providers. And it just takes a lot of time to kind of bring these things up. And so as we change and see a lot of just as there's a lot of change in the measure list, it makes it difficult to have kind of long-standing programs that have impact. The next tenet we have is just really keeping the list relatively short. We've had a lot of interactions with our provider community, and they've really conveyed back to us that they're really only able to focus on maybe 7 to at most 9 measures at any given point in time. So adding a long list of quality metrics might be tempting, as there's just a lot of opportunity to really drive quality improvement, but we overwhelm our providers by doing that. And so we really want to make sure we're focusing on the few things that we're most interested in really addressing. And so that's one of the ideas. And then the last one is just around the clear ability to impact. So making sure that we have kind of alignment in terms of what our overall objective is, and then what activities both the health plan and the provider community can really take to really kind of address that particular measure. So with those kind of ideas in mind, a couple of suggestions that we had around the measure list. The first one is removing the diabetic eye exam measure. So this is an area that we absolutely think is very important as a measure, but is particularly challenging for us to connect and really kind of move the needle on that. And we have a number of other diabetic measures on that list that are really kind of addressing the overall diabetic health for patients. The next one is to consider removing one set of statin therapy measures. Statin is a little bit overweighted in the current list. It's definitely also addressed or identified as an area for improvement. So that's not necessarily a bad thing. But if we're looking at kind of paring down the list, that might be an area to kind of take another look at. And then the last one is to consider adding controlling high blood pressure. This is an area where we think it's pretty industry standard. There's definitely opportunities for improvement. And is a measure that is something that we think would be worth taking another look at.
That it?
That's it.
Nice work.
Just the current measure set. If people are interested in that, but that's where we're at today.
Yeah. As I did with Kaiser Permanente, I ended up looking at what MODA's numbers comparing 2019 and 2021. And for the CCM, there was 9 of the measures, there was an increase, 8 where there was a decrease. For the PPO, there were 10 measures where there was improvement and 6 where it was a decrease. And for PEB, it was 6 increase, 6 decrease, and 1 stable. Again, I think that's remarkable given the impact of the pandemic on utilization. So as I recognize Kaiser Permanente, I'd like to recognize MODA in what you've been able to do. And again, my guess is when we look at 2022, the numbers will continue to improve. So pretty remarkable. The other thing that I looked at was CCM versus PPO in the measures, and for this was only with OEB because it's only in OEB setting that you have a PPO versus the CCM product. 10 of the measures, the CCM did better than the PPO. 5 of the measures, there was the PPO was greater than the CCM, and 1 was they were equal. Again, important information as we look at is the CCM an economic model, or actually is there something behind it in regards to improved quality of care? And this is pretty demonstrable that it shows that there is an improvement in quality when people are in the CCM, and that the long-term conversation we'll have is how do we continue to move people into the product that controls costs and improves quality. And it sounds like, with a 77% of your population in that product now, that's pretty darn remarkable, and definitely the direction that we're hoping for. So nice work.
Thanks. And Dr. Soltabo, just to point out, before we moved to CCM 2.0, we had about 44% of our enrollment in CCM. So that's a pretty big increase.
Yeah, absolutely. Any comments or questions from the rest of the committee? Okay, so thank you very much. We're now going to switch over to the Providence Health Plan, which is the major provider of care for PEB. And we have with us, as you see on the slide, Rebecca Allen Haima and Dr. Robert Gluckman. And welcome you two, and away you go.
Thanks very much, Tom. I'm going to get us started and then turn things over to Becca as we go forward. Can I have the next slide? We haven't been here in a while. I know there are a number of new members, so I thought we might just get a little bit grounded as to who Providence is and how they provide care for the PEB members throughout the state. So I think 160-year tradition, large health system, 7 states, and really what we try to do here is harness the creativity, energy, and quality performance that we have in our health system and bring that forward locally. Just to give some perspective, because we have a large number of providers that are employed, but the majority of the PEB members are cared for by providers who are not employed by Providence. So approximately 2/3 of the choice members, the medical home model, are not Providence employed providers or PCPs. And in the statewide plan, probably almost 90% of the members are cared for by PCPs when they have a PCP who is not a Providence provider. So what we really focus on is the ability to harness the things that we learn from being a provider-sponsored plan with a distributive network and carry on that quality performance throughout the state. And I think that's something that's really unique to us. Another comment I wanted to make as we get grounded is that earlier in the presentation, there was a look at the benefit levels, and it was commented on that the cost share is somewhat lower in PEB overall than it is for OEB. We think that preservation of lower cost share does help drive better adoption, especially in the treatment categories. As you know, for prevention, members don't have a cost share. But as you see our results going forward, you'll see how we stand alone. And we do think that first of all, I just kind of think we ought to give a shout out and a thank you to all the providers on the front lines who have been struggling with how to adapt to care in this pandemic, and have been able to really maintain performance and excel, which is what you're going to see when I show you the numbers. And I think we owe our providers a big debt of gratitude, both hospitals and physicians. And I think it's also a testimony to the energy and creativity of the plan and engaging of those providers. And Becca's going to comment a little bit about how we help support providers. Another question that was asked earlier was looking at a little bit and wanted to understand the actuarial value of the plans. And I think that that'll be an interesting presentation, but over time, with the 11 years that we've had the PPO and a large share of the medical home products, that we have been under the 3.4% legislative trend that's been mandated, and the actuarial value of the plans have increased. And just to give some further perspective, as patients have moved into the choice plan, our choice plan currently is about 2% younger than our standard commercial book of business, but has a 19% higher acuity level. And in the statewide plan, it's about 6% older than our book of business, but these are sick folks, 35% higher than our overall acuity level. So when you're looking at the performance around management of chronic illness and screening in the setting of that level of acuity, I think that's an important perspective to have. And then lastly, on the cost performance, despite the fact that the statewide plan has these sick patients, the cost trend year to date is negative 1.1%. On the choice plan, there's been some shift of some patients from statewide to choice. So the acuity level is up 6% in that patient population, but our cost trend is 3.2%. And that's before we factor in rebates, which would lower those cost trends by about 3/4 of a point. So I just wanted to kind of frame things up as we now move to quality to give you some perspective on what we've been able to accomplish over the last 11 years in partnership with PEB. And we are so grateful for the opportunity to have an impact on state employees and on the state in improving their health and managing their chronic conditions and improving quality. The slide before you now is our performance for the choice plan. This has, as was noted earlier, about 52% of our total members. It's a little over 50,000 members. The green bars on the left have to do with whether we achieved the targets that we were contractually required to achieve, and we did hit them all in 2019. Those targets were suspended, thus the colors are all gray in 2020 and 2021. But what we published here for you were the raw scores that we had and the percentiles in HEDIS that correspond to those raw scores. Things I'd like to just kind of highlight. Out of the 14 measures that have a HEDIS benchmark in the choice plan, 7 of them were in the 90th percentile, 7 of the 14, and 10 of the 14 were at the 75th percentile or above, which is truly extraordinary performance. If we look at the trends, I think that we have been able to, what you'll see is maintain or improve on a number of measures despite the pandemic. Some of those areas that I'd like to call out, colorectal cancer screening, we actually were able to maintain compared to 2019. It's actually a little bit better. Although there's a minimal decline in breast cancer screening in raw numbers, we are still over the 90th percentile compared to national averages. Slight declines in pre and postpartum care, but still over 90% and above the 90th percentile. In childhood immunizations, we actually have been able to improve our raw score compared to 2019 and improve our percentile in HEDIS from the 66th to the 75th percentile, despite the headwinds of getting people in for care, despite the headwinds of some of the controversy that's gone on in the community on immunizations related to COVID immunizations. We've been able to maintain performance, and for the for the adolescent immunizations, improvement from 2019, a slight decline from the prior year. You'll see that the gaps are very tight on HEDIS benchmark performance, whereas last year 35.5% would have been in the 90th percentile. A slight decline drops to the 50th percentile, and you will see year-to-year variation, but something that we continue to focus on with our providers. Again, in looking at some of the preventive aspects in pediatric care, greater than 90th and 75th percentile performance, and performance that is very close to pre-pandemic levels, or in the case of nutritional counseling, even a little bit better. We're particularly proud of our hemoglobin A1C control measure. That 20.4% is very close to the pre-pandemic level. But if you compare it to the earlier presentations, it's by far the best performance that we have for the public employees. It's extraordinary performance. We acknowledge that we have some issues around the statin therapy. I think that there's an opportunity there. Going to call on Becca a little bit later in the presentation to talk about a couple of these areas where we know we need to improve. But again, on controlling high blood pressure, again, 90th percentile performance, by far the best performance on the public employees that's been presented, something we're really particularly proud of. The hospitalization for mental illness, previously we performed in the 90th percentile. There's a significant drop off there. I would kind of point out that in the what we found is that in the setting of the pandemic, when access was compromised, we had providers be somewhat innovative and have non-mental health professionals, and in some cases non-licensed professionals, reach out during this period of time to see how patients were doing that doesn't qualify for the metric. Becca, when I call on her a little bit later, is going to talk about our efforts in this area to be sure that we have proper, we meet metrics, we meet performance. But I did want people to know that in the pandemic, with the challenges, there was some adaptation in a way that actually lowered metric performance that may not have had a negative impact on patients. And then you can see, as was alluded to earlier, some challenges around SBIRT and tobacco smoking prevalence measures. Kaiser already alluded to some of this. I just would point out that those measures have retired, and there are issues around data capture, which are significant drivers here. And over 90% of our choice plan physicians are in PCPCH. I'd like to move to the next slide, which looks at our statewide performance. Overall, again, I would note here that out of the 14 measures with benchmarks, 2 were in the 90th percentile, but 9 out of 14 measures are the 75th percentile or above. Again, as I mentioned earlier, these patients are patients who choose not to have a medical home model. Many of them are more ill, have relationships with specialists that they prefer to have a non-referral base program. We are considering whether we would be removing in our medical home model the referral requirement, and we'll bring that forward to PEB. But again, what you'll see here is really strong, extraordinary performance. Although there's been a little decline in, well, first thing I would just mention is cervical cancer screening is higher than it was pre-pandemic. Colorectal cancer screening is a significant improvement over prior year. It's slightly lower than the 2019 measure, but again, out of the programs presented today, is still higher and is still in the 90th percentile. Breast cancer screening, there have been capacity challenges in the community with the pandemic and workforce challenges, but we're very close. Timeliness of prenatal care has been a slight decline, but still 75th percentile performance. Immunizations on the adolescent side has improved substantially, and we're very close on the childhood immunization size. And some of the other issues around children's counseling about obesity management and lifestyle have declined some, more in the statewide plan than in the other plans. Diabetic control, a slight decline, but still 75th percentile. And again, I would say that this is either better or very close to the other populations that were reported today. And controlling high blood pressure, again, is not quite as good as 2 years ago, but again, compared to what you've heard earlier today, is stronger, very strong. And there's some opportunity, I think, for working harder, but 75th percentile performance among a population that is sicker and chooses not to have a primary care provider. Next slide, please. On the retired measures, I think there's a few things that we would want to point out. Again, what we don't have here, because we're reporting raw data, the observed versus expected is we have plan-wide data. But when you consider the acuity of the population, these are going to be extremely strong numbers. I'd really like to call out that planned all-cause readmission level. Those numbers that you saw earlier are in the 5 to 7% range. That statewide population of a 3.4% readmission data with a 35% higher acuity is very, very strong data. So the two things I'm going to ask Becca to kind of coalesce with these numbers are, one, we recognized early on that the pandemic was going to have a major impact on how patients could access care. And we put forth thought and effort into thinking about how we could coach and advise providers on how they can maintain quality under extremely challenging times. So the first area that I'd like Becca to comment on is a little bit about what we did to maintain quality performance in the face of the worst pandemic the country has seen in 100 years. So Becca, please go ahead.
Thanks, Bob. Yeah, so early on, amidst the shutdown in response to COVID, we recognized that our providers were really struggling to just keep lights on and doors open, and rapidly pivoting to a telehealth model that was really new for everyone. And telehealth had very minimal to no use among most of our provider groups prior to the onset of COVID. And so there was really little to no knowledge of how to continue providing quality care in the telehealth setting. There was very minimal guidance from NCQA early on about how to apply the HEDIS specifications in a virtual environment. So our team very quickly did a very deep dive on all of the HEDIS specifications. We crosswalked every HEDIS measure against the guidance outlined from NCQA on how to code, how to document, and we provided comprehensive guidance to our providers via multiple virtual telehealth summits. And we recognized that our providers were just having to pivot so quickly and so frequently that we just continued to update this guidance that was really, really embraced by our provider groups, because they were trying so hard just to continue to see patients that they didn't have time to figure out how to code for HEDIS, how to bring it into their workflows. So we just served it up to them in this really easy to digest format. And we also crosswalked it with our payment policies so they could also translate back into their billing so they could ensure they would get paid for these services as well. And I think you'll see that reflected in the numbers that Bob presented, that although we saw some dips in some of the more in-person measures, we were really, really able to continue maintaining our quality performance throughout 2020, which was a very, very challenging time. Additionally, most of our providers who care for PEB members are enrolled in a pay-for-performance program. And in addition to just the challenges in adapting to a virtual environment, we saw that there was a financial crisis as well. So we decided to pay out the withholds in full for the duration of 2020 for our commercial pay-for-performance program to support our provider groups. But we continued meeting with them monthly to share their quality data, and we really wove together their quality performance, their opportunities with additional learnings that we had for how to continue bringing in quality through their virtual visits. And that not only included visits that could be completed virtually, but for breast cancer screenings, A1C testing, things like that, we developed best practices for them to connect with their patients virtually and place all the orders during that visit, and encourage their patients to go complete those visits after the virtual visit so that they could just continue to keep the ball rolling as much as they could.
And one thing I kind of want to highlight here is that part of our philosophy is to really be sure that we have robust internal capability to serve our population. We do use we do have some vendor relationships. We do tend to target them to specific populations, but the ability to provide a lot of this expertise and service internally does keep the administrative costs for PEB down. And as we look forward to the challenge of a 3.4% world and the worst inflationary times in 40 years. Anything that we can do, we think is of benefit. So I really want to call out the level of expertise and rigor in our internal programs, while we also do work with vendors. But that's what we think drives the best results as much as possible. And I think we've been able to present that to you today. The other area that I actually wanted Becca to spend a few minutes calling out before she goes into her portion of the presentation is the issue around improving our mental health follow-up after someone has had an emergency room or inpatient visit, because that is an area that workforce has been a bit of a challenge, and we've fine-tuned things a little bit. And Becca, please go ahead.
Thanks, Bob. So you'll see there are a few follow-up behavioral health measures on this slide that are retired measures, and I think my comments really apply to all of these. But if you could go back one slide to the one that's still currently in the program, so it's the follow-up after hospitalization for a mental illness measure. That's the one that we're still reporting on as part of the PEB performance guarantees. Bob did note that we found there are follow-ups being completed by MAs or primary care providers. This measure does require a licensed behavioral health professional to count toward the measure. So we found that there's kind of two buckets of instances where the care is being provided but not reflected in our rate. The first is what Bob spoke to. The second is that this is just a very, very complex measure. And I think with all of these behavioral health measures, there's a big learning journey from translating the frontline care to reflecting it in the HEDIS rate, and getting the appropriate care documented correctly and coded accurately so that it can reflect in the HEDIS rates has been very complex and challenging, especially amidst multiple measure revisions in these complex behavioral health measures. So I think that can speak to some of the declines in this measure. I'll also note that these are relatively smaller denominator measures, so it's not unlikely to see bigger rate swings in either direction. This year, we've been really, really engaged in our behavioral health performance. It's been a strategic area of focus for us. And in August, we launched a new process through our care management program. They've always done follow-up after ED visit calls and follow-up after inpatient stay calls, but we now have psychiatric licensed nurse care managers who do follow-up calls for patients discharged with a mental health diagnosis. And they do an assessment of that member to determine if they need a more in-depth follow-up, in which case they facilitate the appointment with an appropriately credentialed provider. If they only need a brief check-in, they can do a transitional care management appointment over the phone, and either one would meet this metric. So we're not only making sure that the patients get more timely care, but we should be seeing improvement in this rate as a result of that workflow that went into place in August.
So Becca, I think we can kind of move forward to your slide. We have to advance 2 slides, please.
Yes.
And Bob, I wanted to comment on comparing choice to PPO. Amazing, 10 out of the 11 measures, if you're in choice, you did better than in the PPO. Only one of the measures PPO did better than choice. What an impact on of being in the choice product. And that's one of the things that struck me. And if I was on the PEB board, I would be saying, what do we do to continue to encourage people to go into the choice product as compared to the PPO? Now, and I understand that there's a huge number. You already talked about why some people choose that versus the other. In OEB, the reason that people moved from the PPO into the managed product was because of benefit improvements, decreased costs.
Yeah, there is a very substantial difference in benefits today between choice and statewide. So,
Okay.
I think that there are some things that we're going to be talking about to the PEB board about maybe some changes in some benefit structure. I also think that we can't get away from the fact that there's differences in the patient population as well.
Absolutely.
That
Absolutely.
acuity
Yeah.
piece is a big deal, and
Yeah.
we'd have to maybe take a little closer look at the geographic distribution and how we can address some of those potential inequities. So I think that there's a lot to be done, but even the baseline performance in the statewide plan, 9 out of 14 measures, 75th percentile or above, compared to the country in a very acute population, is something we are serving that population well as well. And thank you for the opportunity.
Yeah, thank you. Okay.
Thank you. So I won't go through each of these individually. I think all of the measure changes for 2022 have been reviewed already. But we'll say that in response to being given an opportunity to speak to potential changes to the measure set, we don't have many recommendations because we largely support the changes that were made for calendar year 2022. A large reason for that was because the changes that were made really align with the national ratings programs that we're a part of, and then also really aligning with previous comments that these are the measures we have in our incentive programs. These are the measures that other payers work with their clinics, and so it really just supports overall metric alignment and simplicity, which I know our provider groups really appreciate. With the addition of some CAHPS measures, this is a newer strategic area of focus for PHP, and I think the voice of the consumer is becoming a more powerful one in the health insurance industry. So we welcome that addition, and we're in the process of building a more robust member experience arm of our health plan, and we think that that's a very important thing to include in ratings programs, because we know that the member experience with our health plan is challenging and complex, and needs to be an important factor. And then one comment on the ECQM measures, which are SBIRT, cigarette smoking prevalence, and meaningful language access. These are all things that we have workflows built around. We do engage with our provider network, but just due to the nature of them being CCO metrics, our providers do have trouble reporting on them because they are built for the CCO population. We've been doing really extensive work to really build our muscle around health equity work in our organization. And so we would really welcome the opportunity to have a meaningful measure in our performance guarantees related to health equity. I do think that the meaningful language access one is a bit of a challenge given that it's CCO based. We do have a social determinants of health screening requirement in our commercial P4P program, and it mimics the NCQA measure that will be coming into play. So we would welcome something like that, or really any type of metric that helps to move the dial on equity within our populations. Next slide. So we had a few comments on considerations for near-term incorporation. I think every payer has talked about controlling high blood pressure. It is a very important measure, and it also has disparities among different racial and ethnic populations, and it can really reduce the risk of developing serious conditions like stroke, heart attack, heart failure, and kidney disease. So we feel that this is a very important clinical outcome-based measure or outcome indicator measure to have in the program. Well child visits within the first 30 months of life. There have been a number of comments about delayed impact of COVID, and one of those I think that we'll see in this year and next few years is in childhood immunizations because of the look back period in that measure. And so well child visits in the first 30 months of life is an important driver of childhood immunizations, and it's just a really good engagement opportunity for young children with their pediatrician. So that's the next recommendation. The last is cervical cancer screening. This one is also likely going to see a bit of a delayed impact on COVID. So we're continuing to see strong performance, but it's likely in the next 2 to 3 years, people who delayed their care during 2020 and 2021 we'll start to see that rate decline. And so this is an important prevention and early detection screening measure that we would recommend for near-term incorporation to kind of prevent that decline in from the impact of COVID from those who delayed their care. Next slide. And then we have 2 measures that we recommended for medium-term incorporation. We do think these are important, but we're not ready to incorporate them quite yet. The first would be the depression screening and follow-up NCQA measure. I think this is something that a lot of payers are really wrapping their arms around, but this is a new type of NCQA measure that was recently released. It's called ECDS, and it's requiring provider groups to build new workflows for submitting data to payers. So I don't think that clinics are really ready to universally submit data for this type of metric quite yet. But I think that this will become a more, I believe that this is being added to required reporting in the next 2 years. So we would recommend this for a more medium-term incorporation instead of immediate. And then the last would be initiation and engagement of substance use disorder treatment. I think this pairs well with SBIRT. It's a very important metric to track those who have substance use disorder and whether they're getting treatment. But amidst the current behavioral health staffing crises, we don't feel that it's the right time to add this metric into the set. I think that was the last slide I had.
Okay. Thank you very much for a very thoughtful presentation. There's a lot of commonality in terms of the 3 plans and their recommendations for how we move forward with what metrics that we continue to look for. The idea of consistency and clarity is for real. We will be working with OEB and PEB staff and the plans as we look at coming up with what we're going to propose for PEB. It's the 2023, I'm sorry, it would be 2024 plan year, and for OEB it'd be the 23-24, and that contracts obviously for this coming year are set. So that is something that we will be working on. I am continually impressed by what happens when people are in coordinated care models, let it be MODA's or Providence's choice plan and Kaiser Permanente, that there's an in general, there's improvements in health outcomes, or at least the metrics that we use. And so it'll be interesting to see how we can continue to move that issue forward. Is there any comment that any of the SEOW committee members would like to make? Otherwise, we'll move it on to Glenn to kind of close things up. So Glenn, are you there?
Yes, I'm here.
Okay, so in terms of I have it down that you're going to give us a wrap up and next steps. I gave a little bit of that in terms of us working with the plans. This is an area the PEB and OEB have committed to have consistent measures, quality measures, because we want to again have a consistent request to the to our clinician partners, and our goal is to continue that. So Glenn, anything you would like to add?
Well, yeah, in regards to our measures in for 22, we actually came up with aligned measures working with Mercer and the Innovation Work Group. They came up with a set of totally aligned measures for all the plans, a new process for determining fees at risk, which really relies more on the benchmarks themselves. And that will go into place in 22. We'll get the report in 23 and be able to come back with that. But that is, yeah, it was a totally aligned set to really get away from any kind of inconsistency. So that was to just follow up with that. In regards to next steps, and kind of wrap up, we of course had with the PEB OEB 101 that the need for actually to do a 102 that looked at a number of areas such as funding and different areas of risk scores. In regards to I want to just give a little brief about next steps in regards to this PEB OEB pilot project. Next month, we'll be looking at the additional cost tier, kind of the future of the additional cost tier for PEB and OEB. We also will have, similar to this presentation, for our dental performance measures, we're going to have the carriers come in and really provide their reports on that. The last item would be we were looking at the use of no cost sharing for medical benefits, and a possible policy for that or policy recommendations. And then the last thing, as you pointed out, Tom, was to come back in the spring. Mercer and staff would come back with recommendations, working with the carriers for 23-24, in regards to measures. So, and we thought that'd be another really area where it would be good to have alignment between PEB and OEB.
Great. Okay, thank you. Any other questions or comments? Otherwise, we will adjourn. Yes, Greg.
The only thing I wanted to add was I wanted to thank all three for coming in and giving actually a really good report and getting us kind of online to start what we're actually looking for. And I wanted to thank you guys as a board for, I don't think you specifically, but seeing a need to kind of align both of these since they've been kind of put in the position to be aligned. So thank you for that as well.
And thank you for your participation, both you and Andrea. It's this is an experiment. We're going to see whether or not it's something that helps both boards. But when you combine OEB and PEB, you're talking about, I think, about 12% of the commercial population in the state of Oregon. That has impact, and actually it's 12% of the population. Is that right? No, it's 12% of the commercial population that we are covering. And so by being consistent and coming up with innovation, we have the ability to make a difference. Okay, with that, I will close off this month's SEOW presentations. Thanks again for all the participants.